That's not the case, that they might be clinically vulnerable, and with the current levels of very high COVID cases, it may not be quite so simple to come to meetings. I don't want to exclude anyone. Anyway, that's a debate to have for the next municipal year. Okay, Nikki, first item on the agenda. Well, it's not on the agenda, is it? But do we have any apologies, Nikki? Nikki? Well, should we take? I'll take declarations of interest.
Sorry, I forgot to unmute myself. I was just reading them out and then completely forgot. Yes, we've got Deb Glassbrook, Maria Young, Becky Pollard, Gail Muirhead, Paul Illman, Eilish McCarthy, and Mandeep Baines. And Katie Summers is going to be a bit late, so her items need to be deferred till she gets here. But could I also ask you to read out the thing about being recorded?
Yes,
Thank you.
I'm going to do that now because introducing ourselves. So last time I did this without the official wording, so I apologise if I did left out anything critically important. So quite a long and dull announcement about online meetings. So I'd like to inform everyone present that this meeting will be recorded in Microsoft Teams. So I think that's started now. And then will be uploaded and available for repeat viewing on the council's website. Council's officers and partners attending will be asked to introduce themselves before they speak. That's probably one of the most important things. You can introduce yourself when you speak, so everybody knows who everyone is. So to help me manage the meeting, if you wish to speak, can you indicate in the chat section, please, because it's quite hard to, ideally, or by raising a virtual hand, although that's more likely to be missed, but I'll look out for those. And then also that'll avoid us talking over each other. When not speaking, turn off your microphones to mute. And when called to speak, switch on your camera and unmute your microphone and just wait a few seconds. And the usual stuff, you know, I think we all know about Wi-Fi bandwidth. You know, if you do start breaking up, it's always worth switching off your camera. Otherwise, if you can be on camera when you are speaking and off camera when you're not, that might help poor teams to work properly. Okay, thank you. Thank you, everyone. Right, let's go on then to the next item on the agenda, which is declarations of interest. If people have had a chance to, hopefully people will see the agenda. If you've got a declaration of interest on that, now's the time to raise that your interest in the matter. If it occurs to you through the meeting, don't hold back and let us know then. It's better late than never. I haven't seen anybody indicate, in which case we'll move on to questions. And I understand we've got two questions, both from Mr. Tom Lake. Mr. Lake, are you there?
Yes, I am here, thank you.
It's
Tom Lake. I'm elected governor at Berkshire Healthcare NHS Foundation Trust, which provides mental health and community services in Berkshire, community health services, and also information officer at South Reading Patient Voice. Thank you. Shall I read question 1?
Yes, please.
Thank you. This arises from a particular case, but I think it perhaps has wider relevance. Information from carers suggests that child mental health services are failing in a way that's different and more dangerous than those for adults. Adult mental health services include the very extensive talking therapy services, which range from advice lectures in person or online to intensive psychological treatment short of inpatient treatment. In this way, a range of acuities from the mild to the highly acute are covered by a well-organised and integrated service. For children and adolescents, the picture is more fragmented, and evidence suggests that the standard may not be uniformly high. Because of the typical age of indication, ADHD and autistic spectrum conditions play a larger role for children. It's well known that waits for diagnosis can be over 2 years for these conditions. Less acute difficulties are diagnosed and treated by in-school services, but evidence suggests these do not reach the same standard as the adult services. In particular, symptoms of anxiety and or depression in children on the very long waiting lists for ADHD or autistic disorders can be dismissed as due to the very condition for which they've not yet been diagnosed, and they may not receive any support for these while they wait. Even when acute anxiety is acknowledged, where children may be exhibiting suicidal actions, waits for treatment can be 12 months, leading to extensive suffering and loss of normal life opportunities. Children are missing the education to which they have a right. My feeling is that the primary mental health care services for children are more fragmented and of a lower standard than those available to adults on an easy access basis, such as talking therapies, and those offered by practice-based practitioners. Services which are based in school are necessarily fragmented and cannot readily care for children who are not attending school. It's appropriate to acknowledge the very good work done by charities such as Number 5 and Autism Berkshire in this area, but they cannot fully replace a well-organised service. Even if we acknowledge that the present situation is much heightened by the pandemic and its effects on children, should there not be an immediate investigation into this dangerous situation and an urgent review of the commissioning of mental health services for children and young people?
Okay, thank you, Mr. Lake, for a question that's been a real concern. Something we've touched on this Health and Wellbeing Board for a number of years. And I've got Dr. Andy Cichersky, who is going to reply on behalf of the Thank you.
Thank you, Chair. So Dr. Andy Cichersky, I'm a GP at Emma Green. I'm a PCN Clinical Director in Caversham and Urgent Care Clinical Lead for the Berkshire West CCG and Vice Chair of this board. Thank you for your question, and I have quite a lengthy, I hope you can cope with this, but hopefully comprehensive response. So a review of children and young people's mental health and emotional wellbeing services was undertaken in 2020-2021, sponsored by the Berkshire West Integrated Care Partnerships Children and Young People's Board. The aim of the review was to understand the strengths and limitations of our current service offer across all partners, explore alternative arrangements and solutions implemented elsewhere in the UK that have evidence of improvements in key areas, suggest ways of improving our services and where we need to focus our efforts in the next phases of work, understanding what service users, their carers and families, as well as staff, think about the services and their experience of them to capture opportunities for improvement. The full local transformation plan describes in detail the outcomes from the review, as well as the refreshed priorities moving forward. And there's a web link in the paper response. Waiting times to access both assessment and treatment from specialist CAM services remain higher than acceptable across the country, and the situation in Berkshire is no different. This has been recognised by NHS England, who have included a number of targets to improve access to NHS-funded mental health treatment for children and young people, with associated investment in the NHS long-term plan. One of the NHS long-term plan for children and young people mental health's ambition is to have 164,000 additional children and young people aged 0 to 25 accessing NHS funded services. In some cases, funding is still only sufficient to improve access for a limited percentage. For example, there are pilots around the country to try and reduce the waiting times for children and young people presenting to non-urgent, community-based mental health services. The new proposed standard is that children, young people and their families stroke carers should start to receive help within 4 weeks from request for service or referral. However, Berkshire West is not covered by this pilot. Berkshire West CCG and Berkshire Healthcare Foundation Trust are working closely together alongside our local authority colleagues, schools, VCSE partners to achieve the ambition that more children and young people with emotional well-being and mental health needs can access evidence-based services in a timely manner, and this is described in detail in the local transformation plan. The local approach to improve access to support is twofold. Improve the system partnership ability to identify emerging emotional well-being and mental health needs and provide support at an earlier level. Investment to expand the clinical workforce needed to deliver evidence-based interventions to meet the needs of children and young people. There are a number of actions in place to support early intervention. The CCG, alongside our local authority colleagues, commission youth counselling across Berkshire West. In Reading, this is from Number 5, young people. Young people can access these services directly through self-referral, via their school, GP, or any other professional. The CCG and the local authorities also co-commission Kooth, a digital service which is fully accessible online and has a multi-function platform that provides a full range of help from self-guided to professional counselling support available 24/7, 365 days a year, wherever the child or young person is located. It does not require a child to be in school. The CCG also funds early help activities by contributing to the local authority's budget for a number of initiatives aimed at supporting children and young people's mental health and emotional well-being. Given that children who are not in education are supported by the authority, we would expect some of the funding to be used to support children not in school. The CCG also established 3 NHS-funded mental health support teams in our 3 local authority settings, which have built a school consultation model that is working well to enable schools to respond well first time, as well as identify the children and young people that need mental health support teams and wider provider support. Each mental health support team is set up in waves, centrally funded, and covers a cluster or patch working to the outline of approximately 8,000 pupils per term. Mental health support teams are co-located or hosted within school clusters, depending on the infrastructure opportunities in each local authority. Each mental health support team has 3 core functions: to deliver evidence-based interventions for mild to moderate mental health issues, support the senior mental health lead, the programme being led by the Department for Education, in each school or college to introduce or develop their whole school or college approach, and give timely advice to school and college staff and liaise with external specialist services to help children and young people to get the right support and stay in education. The teams provide specialist evidence-based interventions that target vulnerable populations, such as children in care, and for the most frequently occurring referrals to CAMHS, for example, conduct disorder and anxiety, and have to demonstrate routine outcome measures. There are 2 further teams, one in West Berkshire and one in Reading, which are currently being mobilised and which will be operational from September 2022 and will cover approximately 8,000 pupils each. Further waves have not been confirmed. The CCG commissions Autism Berkshire to provide support and advice to children and young people aged 0 to 25 and their families who may have autism and/or ADHD, as well as those who have a diagnosis. Autism Berkshire work in partnership with Parenting Special Children and provide one-to-one support, training, advice and activities for children and young people and their families. The CCG has recently provided additional funding to Autism Berkshire to provide additional support to families whose needs are escalating, a food avoidance course, and additional family mental health and wellbeing support. A link to the website is included in the written response. The CCG have also reissued the Little Blue Book of Sunshine to provide advice and help available in our area to children and young people who might be experiencing low mood or mental health issues. The new version is digitally accessible as an e-book with clickable links and is downloadable from the usual app stores, Apple Books and Google Play Books. Printed versions were delivered to schools via the local authorities. Finally, there is increased collaboration between providers facilitated by the CCG to work to meet rising needs as they emerge, share intelligence and practice to manage quickly changing parameters on existing offers within national rules due to lockdowns. An example of this is the development of self-directed or online group parenting support for families of young people experiencing anxiety and depression. To address waiting times for specialist CAMHS services, the CCG is developing an investment plan with BHFT for the next 3 years, which will enable them to both expand the workforce in the core specialism CAM service and develop new services to address changing needs. The NHS investment includes the expansion of crisis services for children and young people, the development of a specialist service for children and young people with mental disorder and a learning disability, and the opportunity to jointly fund with local authority partners a mental health service for children in care. Alongside this, Berkshire Healthcare Foundation Trust are transforming their service offer, utilising learning from digital provision through the pandemic, developing a new digital offer and building on a quality improvement programme to redesign clinical care pathways. It is anticipated that this approach will result in improved waiting times for children and young people and their families in accessing support. However, our ambition is being challenged by two factors. The first is the unprecedented level of increase in referrals to children and young people's emotional well-being and specialist mental health services over the past 2 years. Referrals to CAM services across the South East region have increased by 60% in the last 12 months, and locally, Berkshire Healthcare CAMS alone has seen an increase of 65%. The acuity, complexity, and risk of referrals has also increased by 30%, now urgent at the point of referral, compared to 13% in previous years, placing increasing demands on the CAMS workforce. The second challenge is that of workforce shortages. We are seeing higher turnover in clinical workforce, with more staff leaving the clinical speciality altogether and the available staff pool diminishing. The CCG and Berkshire Healthcare Foundation Trust are reviewing the services commissioned in the coming year to understand what more can be done to improve efficiency, utilise digital technology, alternative workforce, among others, to manage the growing demand and reduce waiting times. That's the end of the response.
Thank you. Thank you for that. Mr. Lay, do you have a supplementary?
I do. It's a practical one, I hope. In the particular case, and I mean in general, these waiting times for ADHD and autism diagnosis are very long. They're 2 years or so, and they're not likely to get that much shorter in the near term. And once children have been referred to this waiting list, it appears that their early help comes from a different source than normally, because of the presentation of traits of autism. And so they I believe they're referred to Autism Berkshire and so on, but it may be that the referral is not going well, or that something is not going well here. But I think would it be possible for the CCG to look into the effectiveness of this alternate pathway that's provided for children who, after all, have not yet been diagnosed, but are simply on a waiting list? Thank you.
I can certainly take that back to the CCG team involved in, I think it's the Autism Berkshire bit that you're asking about, isn't it, Mr. Lake? So I don't know whether there are any measures of, you know, how Autism Berkshire functions, but we can certainly ask that question.
Thank you both, and that's thank you for your question, Mr. Lake. It's a very real concern, and with waiting lists and straining the NHS before the pandemic was high enough without obviously the added pressures that we're seeing. Right, so Mr. Lake, I think you have another question. Fire away. You are on mute, Mr. Lake.
Yeah, I'm muted again.
Yeah, sorry. Thank
you. Just to say, so this comes from discussions with Reading Refugee Support Group. We have concerns for the potential for radicalisation in the dispersal hotels and accommodation for refugees, especially as a result of the lack of mental health support for the dispersed asylum seekers in Berkshire. The hotels for Afghan refugees are better supported, but concerns are not dissimilar in the context of frustrations that may build up at the length of time people have to stay there against what they were originally told. People's expectations are the key factor to be managed there. In the other dispersal hotels, on top of the trauma people are dealing with, resulting from experiences in their home country and the journey to the UK, there is the huge ongoing traumatic burden of their impending asylum application and decision, potential deportation ever present, on top of the complete lack of meaningful support for people's mental health and well-being. Our concerns are not evidenced as such, but born out of experience leading the group, the Reading Refugee Support Group, this is, through the Forbury Gardens tragedy. A week after Forbury, an asylum seeker with mental health problems living in a hotel accommodation in Glasgow killed 6 people before being killed himself by the police. And Justice for Refugees is lobbying the government to investigate fully the conditions in the hotel and the lack of support that may have led this man losing control. We suspect those conditions are not dissimilar to the conditions faced by people living in dispersed accommodation here in Berkshire. The longer this situation continues, where hotels are used to accommodate people, which will possibly be exacerbated by the Ukraine crisis stretching resources, the greater the potential is for something to go wrong. At the very least, wider interagency conversations need to be discussing this. Mental health support for this vulnerable group is the key to the conversation. Refugees and asylum seekers who've not received a final refusal of asylum are fully entitled to NHS services. Who will take responsibility for adequate mental health services for these vulnerable people?
Thank you, Mr. Lake. I'm going to ask Dr. Czerski again to answer on behalf of the CCG. Other than to say, obviously, this is going to be something that, well, the council is and will continue to be very alert to and want to work very closely with partners, including the NHS, to ensure that asylum seekers and refugees are supported in our town, and obviously with the expectation of much more greater numbers in the coming months, this will be even more important. Paul Myerscough, we're really pleased to see you. If you could switch your camera off until you speak, that would be great. Thank you. Right, Dr. Czerski.
Thank you, Chair. So here's the response, CCG response. So the Bob ICS is in the process of establishing a team that will lead and coordinate the NHS response to the Ukrainian refugees and our asylum seekers who are already living in our local communities. With regard to access to mental health services, the CCG has funded a mental health worker post through the Reading Refugee Support Group, which will provide an initial screening service and help to network across statutory services. The CCG recognises the complexity of the mental health issues that people may be experiencing and that may be outside the experience of current mental health services. We will be seeking to learn from other areas who have greater experience of this and developing an offer to meet those needs.
Thank you.
Thank you.
Supplementary, Mr. Lake?
Yes, I do have a supplementary, and it relates to the Forbury Gardens tragedy. And just to say that the Forbury Gardens tragedy did not arise completely out of the blue. There were concerns about the individual who eventually committed the murders for some time. Now, we understand that there has been an interagency investigation, but not one that the public would see, perhaps. And when I last spoke to the coroner, which some time ago, the coroner had not made a decision on whether to continue with their investigation. So I ask whether there is any chance for the public to really understand the circumstances which led up to this tragedy.
I'm afraid I have got no information on that from the CCG perspective. I don't know if there's any colleagues in the meeting who may have that information to help Mr. Lake.
Yeah, thank you. I mean, I don't know the answer to that off the top of my head, and but we will. I understand where you're coming from, Mr. Lake, and I will find out and get back to you. So thank you very much for your question. I think in the wider sense, it was very short and quite, to the point answer in terms of where the responsibility lies for that. However, in terms of welcoming refugees and asylum seekers to our town, it's clear that responsibility lies with all of us, and obviously the council is central to that. One of the things that I was very struck by with some of our experiences in last year was that the role of the Home Office can be problematic, I think, in terms of appropriate support. We had a report on that, didn't we, to this board, and I think we need to make sure that we go into, this coming period where perhaps more refugees understanding, how can I say, being cynical in terms of understanding where the failures within national government may lie, and making sure we all work really closely together to give the best possible services and support. But thank you very much. Thank you. Right, so thank you, Dr. Szczerski, for answering those questions on my behalf. Right, so the next agenda item is COVID overview. I've got
Chair, did you do the minutes, or did I miss you doing the minutes?
No, I probably completely failed to do the minutes. So hopefully everyone's seen. Thank you, Nikki, for keeping me on track. So also haven't asked if there's any petitions, but I know there's none.
No, there aren't any petitions.
So yeah, so let's go back to the minutes. I'm not going to go through them. People have got a copy of the papers. If there's anything they want to raise in terms of accuracy or matters on that, then please do so now. You've got a couple of seconds, and if you do not do so, we're going to go to Tracy Dashkovich, who is our Director Public Health in Berkshire West, who's going to introduce the impact of COVID-19 in Reading. Tracy.
Thank you very much, Chair. I will just get the slide deck up. That's sharing.
Yep, that's great.
Get that.
Oh, yeah.
Great, hopefully that's coming through loud and clear. Happy to be interrupted as I go. Obviously I can't see hands, so if someone could field that for me, that would be fantastic. The first slide is slightly misleading, such as the pace of change with this pandemic. The key messages have changed considerably over the past couple of weeks, and we are in a position where we are starting to see case rates increase rather than decrease, but I will qualify that as I go through the slides, and also in terms of the way the pandemic is behaving in certain age groups. So I will pick that out as we go through the numbers. So this is the general direction of travel that we were seeing right up until the end of February. It was around this time, obviously, we started to see restrictions being removed, and maybe due to that, but there's always a number of factors that has an influence on the data. We have started to see a week-on-week increase since this. So we have had a small upkick in that. And at the moment, it looks like that has continued into this week, but it doesn't seem quite such a steep upkick. So maybe we are beginning to level off, but we like to have at least 3 weeks data to be able to do that. So to give a sense of that, at the time, at the end of February when this was done, so up to the week of the 8th of March, Reading was shown at 384 cases. We are now up to 642. So we've sort of seen about a 25% increase week on week. What we're seeing there or thereabouts is a doubling over a 2-week period. But like I say, it's been less of a leap in the week 10th to the 17th of March. So hopefully we'll start to see a more favourable picture around that. If we look at the positive cases of COVID that are reinfections, what we've seen this more with Omicron than we have with any other variant of COVID, where reinfection rates are measurable. And we are seeing reinfection happen. We're at about 8% in Reading. So about 8% of cases are reinfection in the same person. That is absolutely bang on in terms of the average that we're seeing across the South East, and a little bit lower than the England average. Positive cases of reinfection, so this is just giving you in finer slices, if you like, and it's giving you numbers of episodes. So people that have had COVID just the once is in this bright blue, which obviously makes up the main part of the graph. then reinfection rates are shown on the tips there in more of a navy. And then just in the middle of the chart there, February, we've seen a little cluster of third episodes in a small group. So a very tiny amount where we're measuring third episodes, but across the country we are seeing those cases. So the way that is showing itself in terms of population spread, this is the way positive cases are showing themselves as reinfections across the different age groups. And we're seeing that mainly in the middle age groups there, so the late teens and up to the late 40s, and that is showing both in terms of episode 1 and episode 2. The gender split is more distinctive as we go into second episodes. There could be all kinds of reasons for that in terms of settings of work, whether it's primary carers or families or all kinds of things. There could be all sorts of things that is influencing that gender split, but it definitely becomes more noticeable with that second episode of COVID. So the change in case rates in Reading over time by broad age group, again, we can see that this is travelling in the right direction. This up until the end of February was showing that very favourable downward turn, which hopefully we will get back to. When we look at this again as that splitting of age, we have seen a huge variation shift, particularly in school children, and we're certainly seeing that now. We're having a lot of challenge in schools, more so at the moment with schools than care homes, where schools are having to manage quite high cases, both within the student and teaching population. So working closely with schools to put in specific protective factors within that is right for their setting and their particular population. So we're working with a number of schools on a one-to-one basis on that. So patients at Royal Berkshire Hospital, again, we aren't seeing cases anywhere near as high as we were this time last year. We can see that that is a much higher peak than our peak in this period. The number of people in the hospital does, however, remain higher than it did at the start of Omicron, so we haven't got back down to pre-December levels, although they are heading in the right direction. Again, we've seen a shift in this graph as well in terms of the past 2 weeks. We've started to see hospital cases going up again, not severe illness and not needing mechanical ventilation, but just in terms of people being admitted to hospital, we are seeing that upturn as we've entered March, and that has continued over the past 3 weeks. So a week-on-week increase over the past 3 weeks. So at the point of this, and it's irrelevant because time has moved on since this was done, but 78 people at the end of February in hospital. Again, we've seen about between a 17 and a 25% increase in terms of hospital admissions. There we go. So mortality rate, the orange is non-COVID-19 deaths, the blue is COVID identified deaths. So these are deaths that have occurred 28 days after a positive COVID test. What's interesting about this data, and obviously you can see how this has fluctuated and has gone with some kind of seasonal variation. Overall, what we're not seeing is high numbers in terms of excess deaths. So at the moment, in terms of number of annual deaths, we are our 2015 to 2019 average. So we're not seeing excess deaths occur at this stage in terms of numbers. But obviously, cause of death related to COVID is something we are monitoring. This is an interesting graph. It gives you that sweep in terms of age and where vaccination uptake by age, and it's a very neat curve as it follows the different age ranges through. So we can see that this bright blue colour here is people that are fully up to date with their boosters. The navy blue are the people that have had their 2 doses. The orange represents the people that have had their 2 doses and their boosters. And then this purple area here, which is our target audience at the moment, is those people that at the moment have not had any doses at all. So what we want to see is this orange stretch and this purple shrink. as we go further into the spring. We will be starting in the next few weeks a rollout of the fourth vaccination. So this will start with, see if I can stop sharing now so I can see you all again. The fourth vaccination will start with the over 75s and the over 12-year-olds that are clinically extremely vulnerable, and that will start in the spring. So we'll be getting ready to start that any time now. And that again will do something about challenging this increase in cases, because while we've seen that change in behaviours with some of the restrictions being withdrawn, it's also coming at a time that we may see waning of immunity from the vaccination for those people that were in that first tranche of people that received it, so they're ready for their boosters. So there's all sorts of factors that could be driving these figures at the moment. Happy to take any questions.
Great, thank you for that. Whilst people gather their thoughts and maybe indicate they have a question, I do have, well, perhaps the thing that weighs most heavily on my mind at the moment in terms of the pandemic, and that's that with the sort of phasing out of a lot of the testing regime, certainly sort of January time, December time, all that, there was a lot of home testing going on, and a lot of evidence that that was helping to keep down numbers that people are so far stating. But that being swept away, I wonder whether it feels to me like we're moving towards sort of flying blind in terms of trying to understand what's going on. And I wonder what your thoughts are, because to me it seems that we've only really got perhaps hospitalisations, which is obviously a really important figure for us to consider. And I don't know whether there's any sort of figures that come back from primary care or what in terms of monitoring what the situation is on the ground. It feels to me that some of the sort of national messages that perhaps just don't worry about it anymore, and yet we know that there's lots of people that do have to worry about COVID, that they might be clinically vulnerable, and also the hospitalisation figures are things that we don't want to see. So I don't know if your thoughts about that, how we actually keep a monitor and keep an eye on the disease, bearing in mind we've lost the sort of a lot of the testing that was in place.
Yeah, I think you're absolutely right, Councillor Hoskin, on that. I think we are in a place where certainly the data from testing, we can pretty much presume at the moment that our case rate is higher than some of the data will show, because not everybody is testing. We certainly haven't got PCR testing being used at the same rate that it was previously. However, testing isn't the only kind of surveillance that is being used nationally. We are taking water samples and all kinds of things to get a sense of the volume of infection within the community. So we are starting to employ more usual forms of surveillance, which isn't necessarily always on testing data. So from a science point of view, it is moving into a more usual business as usual kind of way, so that you've got that continuous surveillance and monitoring. And some of that, as you rightly point out, is testing and is hospital admissions. But where we can't rely on those solely, we do look to other forms of surveillance. And as testing will no doubtably decrease now, because tests won't be freely available, different levels of surveillance will ramp up. So we will still have very clear data coming in from the government dashboard that will give us an indication of infection level across our communities.
Okay, no, thank you for that. So Mr. Tom Lake has put on the comments, there's the Office of National Statistics survey will still be taking place. That's absolutely true. And the Zoe app as well is continuing, even though the government funding has been cut. I suppose and this will be perhaps a conversation to be having over the next month or so. I suppose my feeling is how far will that be at high level? So we won't really know what's happening in our communities so much. But yeah, that's something that we're going to need to get to grips on, isn't it? Yeah,
and certainly at the moment there is no movement to take things at a higher output basis. So we should certainly get it by local authority level, as we have at the moment. There's no indication at the moment that they're going to go county level or anything like that. So we should still get it at our super output level.
Okay, thank you. Dr. Chersky, you're indicating.
Yes, thank you, Chair. Question for Dr. Dashkevich. As a healthcare worker, a GP in primary care, currently we've been told to carry on testing. So can you just assure myself and maybe the public that primary care workers, GPs, and that all the staff in the surgeries will still be able to keep testing, and for how long, if you know that. And the sort of secondary question to your surveillance issue is if we are asked to carry on testing, because we are often in contact with very vulnerable patients, and the last thing we'd want to do is give them COVID, as well as them giving us COVID, is whether that measure will still be sort of a snapshot of what's going on in the public if some ongoing testing in healthcare settings will be carrying on. Yes, that may be slightly nuanced because it's a healthcare setting, not the general population setting, but is that one part of the surveillance armory? Thank you.
Yeah, so to take the second part of that first, anywhere where there is regular testing becomes part of that surveillance triangulation, if you like. So absolutely, in terms of the ongoing testing in high risk settings like healthcare settings, that is being discussed in terms of how long tests will be available, how they'll be accessed. As you know, free testing for the population that disappears fairly soon, in the next couple of weeks or so, and then there is another phase that will disappear at the end of June. So what we're talking about at the moment is how we get them to high risk. Does that include health and social care? So people that are working frontline right across the board, how you're going to access those kits. So those conversations, hopefully we will get the guidance on that come out in the next short while. I don't have a clear time frame on that, but I'm hoping it will be sooner rather than later.
Thank you.
Okay, thank you. I've not seen any other indications, so thank you very much for that. Clearly, in terms of what you've been saying, the vaccination programme is going to be utterly critical in terms of this. Katie Summers, I don't think is with us yet. She's going to be joining us a little bit later, and will be we'll certainly want to. It's got the vaccination update and is certainly the expert on that. So we'll come back to that because we'll be able to have her here for that. But Amanda has just indicated. I think you're going to come for the Vaccine Champions programme.
That's correct. Yes.
Excellent.
Thank you, Chair.
Okay. Thank you.
All right, thank you. So I will be presenting on the Community Vaccine Champions Programme in Reading. Essentially, the focus of this programme is around communication with at-risk groups, addressing local barriers to access, partnership working, provision of COVID-19 vaccine advice and information, and more importantly, the recruitment of community vaccine champions. Okay, so just waiting for the slides to catch up. If we could go to slide 2, please. Okay. So I'll go ahead.
Sorry, Amanda, I'm just trying to sort out so many windows open.
That's
I will
right.
try and find it for you. Is it showing anything yet?
I can see the final slide.
Final slide. Okay, I will make sure I get to the right one then. I've got the other one open as well, so sorry about that. Let me just check.
No problem. So as the slides are being sorted out, I'll carry on just explaining about the programme. As part of the programme, a multi-agency steering group has been set up, and the terms of reference are available on the slide set between slide 13 and 15. So I won't go into detail about those. But if we can move on to slide 3, that will be brilliant. Thank you. So Reading received funding from the Department of Levelling Up Housing and Communities, and including Reading, a total of 60 local authorities are taking part in this national programme. There are some key deliverables, some which I've already mentioned, but the other 2 key deliverables include increased outreach and engagement to understand the local barriers, the needs, as well as to promote vaccine uptake, as well as sharing public health advice. The second key deliverable is around the recruitment and appointment of community champion, a community champions network, as well as the delivery of a local grant, a range of local grant schemes. Next slide, please. So as mentioned previously, some of the key aims are focused around that tackling of misinformation that relates to vaccines, as well as building trust as well and increasing uptake of vaccines. Although the key focus is COVID vaccine uptake, this is a brilliant opportunity to look at the wider health and inequalities issues. And additionally, it's an opportunity to develop the capacity in the VCS through the champions and increase community resilience, which is really an opportune moment to do this. Right, next slide, please. Thank you. Initially, we have decided to take a targeted approach, and just sort of elaborating on the presentation delivered by Tracy, we're trying to focus on the groups or the residents that have been reported to have lower vaccine uptake. So as you can see there, we're targeting the Chinese population, Black African and Asian and Pakistani groups. We're also looking at the younger adult residents in Reading. There'll also be a focus on areas of deprivation, particularly IMD 3 and 4, and specific areas in Reading, which include Central, Leighton Park, Battle and Caversham Bridge, as well as some vulnerable groups such as the homeless, substance misusers, and refugees. One of the key things that we wanted to ensure was that we built on existing vaccine uptake work rather than recreating the wheel. And as a result of this, we've been trying to link in with our PCNs, which is extremely important, and the engagement process around this has started. We've also started to link in with some of the voluntary community sector groups, organizations, to essentially ensure that we're working together rather than duplicating efforts. Next slide, please. Okay. As mentioned before, a steering group has been developed, but as part of this program of work, 6 task and finish groups were also created. And as you can see there, they cover a range of different focus areas, including training, looking at data analytics, focusing on where it is that we need to be targeting and shifting according to need and according to the change in circumstances. Okay, so in terms of the task and finish groups, slide 7 to 12 provides detail about what each task and finish group focuses on. And again, I won't go into much detail about this. However, to summarize as a whole, we're absolutely delighted that we got this opportunity. It has been extremely fast paced. And we've had a brilliant response from the voluntary community sector, and we just want to work on building on this. The initial planning phase has been extremely fast-paced, as I mentioned, but this has been done, and we're now moving into the delivery phase. Positively, we've had approval from the Department of Levelling Up, Housing and Communities, and they're happy for us to progress with our plans. However, due to the pace of the development of the work, it's important that going forward we apply a more flexible approach. And by this, this is referring particularly to this slide, which is showing the allocation of the different funding. So the process will be flexed as we get further insights. And what we will do is ensure that we put the money where it needs to be as we, as we gather further insights. So I'm happy to take any questions.
Great, thank you. Thank you for that. I think this is well, one obviously really important, but also I think this is a really good initiative. I'm really pleased with what you've managed to pull together. I think it's probably worth saying that this had to be pulled together really quite quickly, didn't it, in order to meet, as ever, the timescales in order to secure the funding. So certainly for me, thanks to the officers and partners and everyone that was involved in terms of getting it all together very quickly. And yeah, I don't have any questions because I've seen it before and raised my questions. I think everything is covered there, but other people may not and may either have a question or something they want to raise. I don't see anybody indicating. I mean, clearly, the issue is about how effective it is. So I'm really, interested and excited to see how this works on the ground and, the difference we can make because absolutely, as it worth. And it's probably worth emphasising this is all very much also about the health inequalities situation with case rates high and vaccination rates very varied across communities. There's a real danger that health inequalities are going to exacerbate and get worse with COVID becoming something that is a greater greater impact of disease in communities that are lower vaccinations, which are also connected often with areas of high deprivation. So I don't have any questions. Thank you very much. Unless you've got anything to add.
No, nothing to add. Thank you.
Okay, all right. Well, thank you for that, and we'll look forward very much to how that to how it all works in practice.
Thank you, Chair.
Thank you. So we're still waiting for Katie on the vaccinations and a few other items that she's involved in. So I've got here on my notes that Andy Statham from the Royal Berkshire Foundation Trust to give a verbal update. I don't know if that's we plan to do, Andy. Hello.
Hi, I'm sorry, I hadn't necessarily picked up that we were giving a kind of a formal update on this, but I'm happy to kind of pick up on a few things that colleagues may be interested in on here. So I'm Andy Statham. I'm Director of Strategy here at the Royal Berks. I think Tracy covered a large number of the trends and issues that we're facing, particularly in related to the COVID pandemic at the moment. And she very skillfully, as you'd expect, kind of covered the main trends in terms of the numbers of patients coming forward, and absolutely confirmed that whilst we're seeing that gradual rise in the number of people in the hospital with COVID, it's definitely being the vast majority of those patients are being tested for COVID whilst they're in the hospital with something else. So they're presenting with incidental COVID as opposed to necessarily with COVID as their primary condition. And we have very, very few numbers of people requiring intensive care levels of treatment for their COVID pneumonia. That does not in any means mean that it's not a busy time for our clinical and operational teams. So there's a constant pressure on recovering some of the backlog for elective care that our teams have been focused on. We feel we're making good progress on that, but it's definitely going to be a long road and need to really support patients who appreciate are going to be waiting a long time for their care, or at least much longer than they were prior to the pandemic. At the front door, A&E remains very, very busy with people seeking our care and our support. As with kind of pre-Christmas, there's a large number of people with quite minor ailments, we would say, that would really be encouraging people to look at alternative ways that they might be able to seek care and advice for some of those conditions, be they through one-on-one pharmacies, general practitioners, urgent treatment centres around. So really keen for that, but that's not to say that people shouldn't come forward with their illness, but just remember that we've got a large number of people seeking access at A&E at the moment, and beyond what we're built to deal with. So some of the waits for care at times are disappointingly long, and the team are doing their absolute best to support that. But it's definitely a challenge at the moment. But perhaps more excitingly, we've got some real time to make progress on some of our longer term plans and additions. So we're in the stages of setting that out in some of our strategy work, which I'd be very keen to talk to this group over the next few months, and we're going to be moving into next stages with some of our work about transforming our services and our digital work over the next few months to really create pace and momentum as we get kind of back into good working order, as I'm sure others are doing all this. We're also very keen to be making progress on our on hospital redevelopment work. That's proving to be much slower than we anticipated with the shape that the national programme's taking, and they're keen to be focusing on hospitals that were slightly further developed than we were prior to the pandemic on that, but that is moving perhaps more slowly than we would have hoped, and we're working on how we can work with the national programme to get that investment into the hospital facilities that we've got, and I'm sure people are aware need that kind of investment. I think those are probably the main things I kind of wanted to cover with that time, but happy to pick up on kind of reflections that people might have.
Chair, through you, Andy, I think there was, I don't know if you mentioned anything about progress on elective stuff.
Yeah, I have covered that.
Okay, sorry, I missed that. Must have been.
Yeah, we're doing. We feel we're doing well. There's a lot more to come. So we have very the focus nationally at the moment is on patients who've been waiting more than 2 years for their care. We have a handful of those patients, much lower than some of our national and more local counterparts. That will step through the summer into looking at people waiting 18 months, and then with a focus on those waiting more than a year. Again, we're well placed on that, but the headline statistics will present as if waiting is getting worse, because we're rightly focusing on those with the absolute longest waits. But when you're looking at some of the headline metrics, we'll look at how many people are waiting more than 18 weeks, and that will go up as we focus on those with the longest waits first, which is the right thing to be doing for that. But we feel we're doing well, but as I say, it's not an overnight fix to some of that challenge.
Okay, thank you. Quite wide-ranging overview. I think was helpful. I haven't got anybody indicating. I do have one question which I'm interested in going back to what we were talking about. With case rates rising, and you talked about obviously the difference between people that happen to be in hospital with COVID and people who are hospitalised because of COVID. I understand that. I'm also a little bit concerned about the impact that a generally sort of endemic, circulation of COVID could have on sickness. In your capacity, workforce is really stretched. Even before the pandemic, we know that the NHS was under considerable pressure. We've had pandemic, we've had Brexit has also had an impact on workforce. So yeah, I wonder about your thoughts around how resilient the trust is to an ongoing sort of endemic COVID circulating, causing sickness and absence and long COVID and such like, and if there's any ideas about how to protect or ameliorate that.
So definitely in the last wave, availability of workforce was probably our principal concern in ways that in previous ways, oxygen capacity had been a concern, or ICU capacity had been a concern. Actually, that it became each time appears to be a different challenge, which hospitals are not alone in that at all. So yes, it could well be a challenge for that, and staff sickness has come down, but it's still not down at pre-pandemic levels. But a lot of the absence is still people with household contacts, and so we do need to look at and we're aware that NHS England are looking at whether the infection control advice is keeping up with actually how the disease is evolving, and actually can we go further in a safe way, but also technology and actually the flexibility of our workforce has shown that we can go further about being agile with people who might be not actually sick but isolating. How can we move the work around such that those people can lead some of our video consultation work whilst redistributing the work. But it means people need to be really agile. It's work in progress, and look at different ways of responding to that agility.
Great, thank you. Thanks. That's yeah, I can see it's a challenge. Dr. Cichurski, your hand is raised.
Thank you. Thank you, Andy, for giving us the RBFT update. Can I just ask, from the effect of elective recovery, how much of the work that Royal Berks is having to do is helping other partners across the Bob ICS, especially with the long waiters? Will it affect some of the waiting times on our local residents? Will it be small numbers, or will it have some appreciable effect? And the second question was, I think you touched upon, is about the agility of your staff adapting to things like remote consulting with patients, using video and telephone consultations, very much like primary care GPs have had to do, one, to deal with a workload, but also because of workforce issues and either patients not being able to get to the hospital or staff not being able to be in the hospital, so having to work using digital technologies to provide the expertise that the hospital staff provide. Thank you.
So first question about support to other providers. We as you'll know, Andy, we are providing some capacity in some specialties to support the very long wait positions that our partner trusts in Buckinghamshire and Oxfordshire have got encountering because of challenges pre-pandemic and then exacerbated through the pandemic. We're doing that where we feel we can offer additional capacity whilst protecting the care that we're providing to our patients. We're seeing some uptake of that, but also it's got to be right for the patients to come, and some patients are rightly recognising the quite significant geographies that we've got in the Thames Valley to come across. So uptake isn't massive, and at the moment we don't believe it's materially impacting our ability to perform for our local population. But I think it will be persistent, that the additional capacity that our local systems have got, because we've got independent sector providers as well as ourselves here, we do have more capacity than some of our colleagues in Buckinghamshire in particular. So we're expecting to continue to provide that support where we can whilst supporting Berkshire patients. So your question on technology, again, we've made good progress in that from a relatively low base of people using that. I think that the main challenge at the moment is that we do need to focus on the patients we delayed because we couldn't actually support them during the pandemic when we did quite a lot of work online. So if you look at our online delivery numbers, the headline it's gone down a bit, but I think that's not because of a rejection of digital technology. It's just rightly focusing on patients who we absolutely have to come and see face to face and support.
Thank you.
Thanks, Andy, and thank you, Andy. I don't see anyone else indicating, so thanks very much for that overview and update, and it's appreciated. Thank you.
Pleasure. Thanks, Chair.
Okay, so we think we're still waiting for, if anyone sees when Katie Summers arrives, we'll give her a bit of time and then come back to her. It could be a bit of the Katie Summers shirt towards the end. She's got a few items here. In which case, so no one's wanting to indicate on this item. We'll move on to the Berkshire West Health and Wellbeing Strategy, the implementation plans. We've seen the strategy. This is about the action plans, the implementation plans, and Amanda's back again to present for us. Thank you.
Thank you, Chair. So as mentioned, I will be providing a presentation on the implementation plans for the 5 priorities of the Berkshire West Health and Wellbeing Strategy for 2021-2030. And this is for approval by the board. So the implementation plans presented are specifically for a 3-year period of between 2022 and 2025. And these have been co-produced and developed working very closely with local partners from health, social care, local authorities, as well as the voluntary sector, along with Reading residents. These plans set out the actions that need to be taken to implement the priorities of the strategy, and they include the monitoring arrangements. And it's important to note that these will always be working documents that respond to the local needs. So as stated in the report, the 5 priority areas cover reducing the differences in health between different groups of people, so tackling that health inequalities aspect, supporting individuals at high risk of bad health outcomes to live healthy lives. Priority 3 focuses on helping families and children in early years, and priority 4 and 5 have a focus on mental health, 4 focusing on children and young people, and priority 5 focusing on adults. The implementation plans have been developed for the 5 priorities and as mentioned, and these have been reviewed. They have also been sense checked with input from various key groups. I'll just name a few of the groups that have been involved in the development of these. The Reading Integration Board, the Mental Wellbeing Group, Brighter Futures for Children, the Carer Steering Group, One Reading Partnership, and various other groups have been involved in the development of these. As can be seen from the structure of the plans, they are set out to include the specific priority item description. This has been pulled directly from the Health and Wellbeing Strategy. It then showcases what exactly will be done, so sub-actions that will need to be implemented in order to achieve the main priority. The plans also highlight who will do it and the leads and the supporting organizations that will ensure that the actions are implemented. There's also a final column which highlights the targets by when certain actions will be completed, as well as where certain actions will be reviewed by, which is normal for implementation plans. There are various actions, some which are much longer term and others which may be one-off, and therefore updates can be provided as and when needed. Okay, so we've had a number of challenges as a result of this process. The main challenge just being the amount of time required to develop these, because there's been, a great deal of buy-in in the process and in the action plans themselves. However, what that has meant is that whenever any changes or any key changes need to be made, these need to be sense checked with the organizations that have been contributing. So this is both a positive and a little bit of a challenge, but it's vital to ensure that the process is strengthened as a result of partnership working, and that resources are pulled together to ensure that this is delivered in the best way possible. So finally, as we accumulate experience, as we share best practice and learn from each other, we will make sure that we are reviewing and adapting the actions as needed. In terms of next steps, we are planning to essentially to launch the implementation plans with service users, and we're aiming to engage feedback basically from people who have been involved in the journey right from the start to date, to ensure that we've captured their lived experiences and that these are represented in the implementation plans. We also plan a further launch for a wider group, including the public, including providers and key stakeholders. And the purpose of this launch is to raise awareness of the strategy and the implementation plans, and to encourage pledges and to foster accountability towards the actions. I just wanted to highlight that we plan to provide quarterly updates to the Health and Wellbeing Board with regards to the progress of the actions. And twice a year, the goal is that we'll be able to bring a more detailed narrative report to support the dashboard that will be presented. Thank you. Happy to take any questions.
Great, thanks Amanda for such a clear presentation on that. I don't have any questions. I'm waiting for people to indicate. Obviously, I would like to welcome, the work that's been done here, and particularly welcome, I think, that partnership working that you described, which may add to the length of time it takes the product to come through, because there's lots of people being involved and lots of people need to be included. But I think leads to much better outcomes and is well worth it. So thanks for that. I suppose to everyone, I would add that the implementation plan very much will be evolving document that will evolve and change over time. Just in the last month or so, with the living with COVID approach and what that might mean for health and wellbeing in Reading. Already you can see how we need to adapt and change, and I think this will be something that will happen over time about the adaptability of what we do. So Hannah Laidley has asked a question. I don't think I want to ask it in person, but she's asked basically when the first update on the implementation plans actions is going to be. I mean, obviously committed to quarterly, but Amanda.
Yes, so we're hoping that we'll be able to provide, in fact, we're confident we should be able to provide an update at the next meeting, I believe in July.
Okay, anybody else? Hopefully lots of people have been involved and have seen this and will continue to feel involved and can raise issues on this at any time with us anyway, because nobody else is indicating. So thank you very much, Amanda, for a very clear presentation. That was great.
Thank you, Chair.
Nobody else is indicating, so we'll move on to an update on the Joint Strategic Needs Assessment. We've got Sarah Shildrick. Okay, Sarah.
Hi, thank you, Chair. So yes, I'm Sarah Shildrick. I'm the Public Health Intelligence Manager for Berkshire West, and I'm here today to talk to you about the recent work that's been done on the Reading JSNA. So you will have seen the background paper that's gone out, so I'll pick up on a few key points from that, but what I would really like to do is to demo the site so you can see the work that's been done on the Reading Observatory over the past few months. But firstly, if we think about the two strands of JSNA that were agreed by the board back in 2018, on one hand, we had the automated data tool that sits on the Reading Observatory website. So this was established in 2019 and is in the main provided by Esri UK. And what this is designed to do is to deliver the kind of core JSNA data set, which is automatically updated as data is released. And then on the other hand, we had the concept of a library of resources which assess the health and wellbeing of Reading. And these were being built and put onto the JSNA section of the council website. So what we really had was two strands sitting on two separate websites. So therefore, the work that's been done over the past 6 months is really focused on bringing these two strands of JSNA together into one place. And in order to do this, what we've done is we've enhanced the Reading Observatory site, and we've brought this library of resources that were on the council website over to join the existing data tools that are on the observatory site. So what I'd just like to do now is to take you all through some of those developments on the site now. So I'll just share my screen. Hopefully this will work. Okay, is that displaying okay? You can see the observatory site. Great. So firstly, anyone who's kind of familiar with what the site looked like before, you'll see immediately that we've done a kind of rebrand of the site. We've moved away from the more generic kind of blue colour scheme and replace that with the Reading kind of colours and logos. So we've highlighted the site as being the home of the JSNA, and all of the other kind of homepage features that were on the previous version of the site are still here. So we've got the ability to look at ward profiles by either selecting a ward with the mouse or searching by postcode. We still have the kind of themed reports over here, and they're available for a wide range of geographies. So from Reading local authority level right down to lower super output area or neighbourhood level where possible. So the data tools that existed on the previous version of the site are still here, and they're all now grouped together under this data toolbox. So obviously I've not got time today to go through each of those in turn, but what we have done in the support section over here is we've added these video guides which guide people with instructions on how to use those various tools. So now to kind of the new content, the new features of the site. So firstly, the COVID-19 recovery report here. So this has been developed to kind of take people through key measures across the life course that will have been impacted upon by the pandemic. So this is one of the reports that's really going to be built on over time as we learn more about the effects on the local population and as we start to bring more and more data into the site. Then looking at the needs assessments and further resources. So this is really where we've brought that kind of library of local needs assessments over from the existing page on the council site over to the observatory here. So you'll see those starting to appear up here under local needs assessments. And then we've also got links to local websites and national websites that all contain information about the local population of Reading. And this page will really grow and grow as we get more and more needs assessment that start to build up the kind of library of resources that we've got around Reading. And what we'd also really like to do going forward as well is to start to accompany these needs assessments with some kind of easy read versions, easy read summaries to make the JSNA more and more accessible. The next new feature is the JSNA summary reports. So these are split into two sections, one on place and one on people. And this is really where we're trying to combine the kind of power of the automated data updates along with some kind of interpretation and wording that we've brought in from existing assessments and plans such as the health and wellbeing strategy. So I'll just go down to kind of give an example of how that works. So if I start looking at the first section, which is around the local environment, and this first part here is looking at climate change. So if we look at kind of the numbers and all the charts that are in here, all this information has been brought in from that underlying database. So all that data will be automatically updated. And then that's accompanied by some interpretation and assessment of that data that we've brought in from the climate change strategy. Similarly, if we look at transport, again, all the data and the charts, that information is being pulled in from this underlying dataset database and will automatically update when that underlying data source updates. And then the wording has been brought in from the transport assessment and plans. So the final three features that I'll take you through now are really more about kind of supporting people's use of the site and getting people engaged in supporting any further development. So firstly, the news section is where we will update people on any new features or new data that's been introduced to the site. For example, if a new needs assessment has been published, that will come up onto the news page. Under your views, we have a short user survey. So this is really to gain some insight about which people are using the observatory site and what they think of it, and it gives an opportunity to make any recommendations for further enhancements. Finally, on here we have the support section. So you can see an FAQ section that's describing the process behind the observatory, Reading's approach to JSNA, and some information about needs assessments as well in there. We have the video guides that I mentioned at the beginning, so taking people through an overview of the site and then some more detailed videos, instructional videos about how to use these features that are under the data toolbox. And then finally in the support section, there's some contact information as well for anybody who requires any further information. So that's that there. So I'm going to just stop sharing because that's all I really wanted to share with the demo of the site, and appreciate that was quite the whistle-stop tour, but I'm happy to arrange with anybody to sit down and look further at the details within the site. So I really just wanted to kind of finish by saying that this is can really be seen as the foundations that we want to build on the vision for the JSNA as being the single point of intelligence for commissioning information. And we really feel like the only way to really continue building on it as a resource is to promote the site, to promote the JSNA vision, and to really get more and more people using the site and contributing to its content, particularly that section around needs assessments and profiles. So to do this, we were asking the board to nominate what we're calling observatory super users from each member organisation and departments. And the idea is that these users will be guided in detail on all the features within the site so that they can in turn support other people to use it and continue to build on the local data and intelligence that's in there, as well as the promotion of the local JSNA. Thank you. I'm happy to take any questions.
Thank you for that. And I think what you touched on at the end is obviously really important. We need to ensure that, because I think it has been said that, oh, we don't know anything. Levels of knowledge of this has been low. So about ensuring we can use our network and communications to do that, but also perhaps, Nikki, we need to remind this action as part of when we email out to our contacts from this board in terms of action 2, which is about nominating the observatory super users representing their organisations. Any questions, any points? And Dr. Andy Czerski has raised his hand. Andy.
Yeah, sorry, Chair, another one from me. Sarah, great, thank you for that presentation. I did actually have a little play with the observatory, and it's a bit like a candy shop, isn't it? There's so many, good things in there. The question I had was, with a lot of the integrated working and using connected care as a sort of a joint health record, is there any information that the observatory can, we can't use all tools all the time because we've got to try and focus on using something that's consistent, but does the observatory data help support connected care in any way, or maybe more strategically, can what is in the observatory support those who are designing how connected care is being used, maybe use the observatory data to direct people how to then use connected care more usefully? Do you understand what I'm saying? You don't want to use too many tools, but can one help the other?
Yes, I think so. And I think it's almost like that kind of different layers of information. So how I would see it is almost that the information on the observatory is that more high level, very well kind of validated demographic information. But if you wanted to dig further and deeper into kind of the more kind of individual population groups and different health conditions, then that is when I would move more towards the connected care data. So I think it would be kind of using in parallel, but like you describe, almost what you find from the observatory, guiding what you then start to dig around within connected care and the kind of the system insights tools and things like that.
Thank you.
Great, thank you. Anybody else? Can't see anyone. So thank you, Sarah, for that overview. I think I'd like Andy, I had a little route round, and well, I love all that kind of stuff. So yeah, really enjoyed you know, sort of scouting around Reading, looking at all the details of the local information. The really important actions on here are around the super users, and so I'm going to look at the chat because I think people are saying things, and so I think what we're going to need to do is to following on from this meeting to communicate out, to request that information from the groups of this partnership. So people bear that in mind, and hopefully they're all agreeing at this board meeting to that, and also about you know, thinking how we actually raise awareness as well of this. And do you want to ask the question that you've got there? I was trying to.
Yes, thank you, Chair. The question was just, as a super user, will there be any sort of functionality that allows super users to be updated when new needs assessments are added, or any changes, or is it the case that they will just need to sort of frequently check and see if there's any new additions?
Yes, so we have the news section, which will update all users as to when there's new needs assessments on there, and we'd like to try and add kind of an RSS feed to that so people can sign up to email alerts for that. But in terms of the super users, what I'd also see them being part of is kind of almost developing a kind of inventory of when needs assessments are going to be done, so they've almost got that kind of preemptive information around new needs assessments as they come out. So it's part of this kind of process to ensure that we know what needs assessments have been done. They're done with JSNA in mind, and in mind that they will then join the library of resources on the observatory as well.
Brilliant, thank you.
Great, thanks. I've got Councillor Jason Brock indicating. Jason.
Thank you, Chair. I love data, and I like data when it's broken down by areas as well, which makes me want to ask, I mean, so the breakdown by wards is useful, and councillors, I'm sure, will be particularly interested. But those wards don't exist in 7 weeks' time, and we implement new wards. Can it be updated to reflect that, straightforwardly enough?
So in terms of any new data that comes out in the future, it would be straightforward. It's not easy to retrospectively go back and update the information as ward boundaries change. So there is a feature within the site that is slightly more kind of an advanced feature where you can identify kind of custom geographies. So that's one way we could look at doing that, is to kind of almost build those wards up from output areas in order to present the data for those wards. But yes, it's tricky to go back retrospectively.
Okay, that's a shame. I mean, the new boundaries were published about 18 months ago, but that's fine. We'll work with what we've got. Thank you, Sarah.
Thank you, Jason. You weren't the first person to raise that as an issue, but I think that's, you know, not easy. Okay, anyone else? Okay, well, thank you very much. And so yes, looking out for the observatory super users. We'll be expecting a rush of people volunteering for that. So thank you.
Thank you.
Right, so I don't think we have Katie Summers yet, so we'll move on to the Berkshire Healthcare NHS Foundation Trust, the Mental Health Strategy 16 to 21 progress update. Catherine McDermott, hello. Over to
Hello,
you.
thank you very much. Thank you, Chair. I'm Catherine McDermott. I'm the Director of Strategic Planning for Berkshire Healthcare Trust, and I've been asked to give you an update on the current mental health strategy, which I will do. But very quickly to point out that this is the last year of the strategy, so we've already started to work on developing a new strategy, and I can talk more about that at the end if that's helpful. I'm going to assume that everybody's had an opportunity to read the update, but there are some key messages that I wanted to share over the life of this plan. So we've made significant progress in integrating our mental health services with physical health services and primary care networks. We haven't finished doing that. We have started and we've made a fantastic start. That's very much work that's ongoing and will continue. And colleagues who are aware of what's called the R's roles, the additional role reimbursement roles that are funded within primary care, also include a number of mental health practitioners. So that's really fantastic to increase that capacity within general practice of primary care networks. We've had a programme of work that's dedicated on reducing variation in outcomes for people with serious mental illnesses. Those of you that are a bit more au fait with BHFT will know that we set ourselves challenging targets called Truth North goals each year and have driver metrics. And we've included a specific target around increasing the numbers of people who have a serious mental illness having their physical health checks. And we've already achieved the target that we set ourselves for next year. So that's absolutely totally fantastic. And that will obviously have a really great outcome for our people with serious mental illnesses. We've extended the wellbeing services staff in BHFT and the Royal Berks. We did previously have a staff wellbeing service, but with the onset of the pandemic, we significantly escalated the wellbeing service available. And as it says on the tin, we provide it to some of our partner organisations as well. Mainly because of the pandemic, although we did have some really exciting innovation pre-pandemic, there's been a significant extension in the offer of our services in digital means, things like Sharon for the IAP services. There have been significant increases in people being able to remote access appointments. Some of our family therapies will say that this has actually helped increase access because it's enabled families to be able to, dads in particular, be able to join family conferences where previously, because of work and travel time, it was more difficult. So that's been a really positive. We've been able to include what's called lived experiences as people who have lived experiences of mental ill health and using our services in designing and delivering our services. So that's been really exciting. And that has helped drive some really great relationships with our voluntary and community sector. And that will be a big part of our new mental health strategy going forward. We have improved inpatient experience, and in terms of Prospect Park, our hospital, we've done significant work around the use of prone restraints, and we now have shifted to being one of the better trusts in terms of not using prone restraint. So they're really some of the key messages I wanted to share in terms of the actions we set out in the original strategy. But of course, during the time of that strategy, we then went into a pandemic, and I couldn't really provide an update without saying that has had and will continue to have a significant impact on the mental health and well-being of our populations. We're already seeing, and we have done for a while now, seen a significant increase in the referrals into the services. And Andy mentioned the CAMHS referrals earlier in the meeting. And we are seeing significant CAMHS increases, eating disorders amongst young people. Not only are we seeing a lot more people, what we call the acuity, so the level of illness is a lot more severe. And I think we've only started to see the impact that the pandemic will have on people's health and well-being. And when you throw in things like wars and recessions and unemployment and housing, you do have quite a fragile landscape. Some of that we've been able to manage because we have escalated the use of some of our digital and remote monitoring. But as you can appreciate, within mental health services, a lot of it does need to be face-to-face because it's that personal contact that really makes a difference. So it's going to continue to be challenging in terms of delivering mental health services. Our new strategy is clearly going to have to reflect some of those challenges we have going forward. As mentioned, we are now looking at developing a new strategy. We will do that in partnership with others. We have other innovations coming online. So at the moment, I've began to lead a piece of work around mental health services and our locality MDT, so how we can integrate those better together. The work around mental health integrated services with primary care networks is very live and will continue to be very live. And of course, additional capacity within both BHFT and general practice through those additional roles will be key to making sure that we can manage this going forward. So I'm going to stop there. I'm very happy to take any questions if people want any more detail on anything that I've covered off, possibly too briefly. Thank you.
Great, thank you. I've got Dr. Andy Czerski indicating. Andy.
Thank you, Chair. Thank you, Catherine, for that update. Workforce, as you say, is an ongoing challenge, and it's welcome that we've got mental health practitioners coming into primary care. Our practice, our PCN, has got that a new mental health practitioner working for us. My slight concern is with all these things is that is there a limit to how many mental health practitioners there are out there? And to some degree, are we robbing Peter to pay Paul by taking practitioners that could be working for you but are working for us? I mean, like I say, we're very grateful. We've got primary care mental health practitioners working at the coalface with patients that, you know, as they come into primary care, and maybe be catching them and putting their expertise to the patients before they get worse and may then need secondary care needs. That's the whole point of, I think, the working, is that we catch people earlier and try and offset that leading into crisis. But it is a bit of a concern that there's a limit of trained workforce out there. So is there any pipeline for mental health practitioners? Do you know that, are you feeling reassured that there will be staff somewhere coming along to fill your vacancies as well as filling the new roles? Or are we forever going to be using a more dwindling resource?
So that is a real challenge. I won't pretend it's not. It's a challenge for us, but it's a challenge for all mental health trusts. The issue is fundamentally that it takes time to train people to be mental health practitioners. And if you haven't invested in people going to university, doing the degrees and then the appropriate postgraduate qualifications, you don't have that pipeline of new people coming in. So the scenario of, you know, Peter robbing Paul is unfortunately a bit of a scenario that's going to continue going forward. So I think we can't just rely on trying to recruit. I think we do need to look at what roles we can do differently. The new strategy that I'll be working to develop will include that. I think there's more that we could be doing with our voluntary and community sector. So it's that earlier prevention work rather than just having that medical model of dealing with people in crisis. So I do think there is something that we need to be thinking about. What can we do more on the prevention side, more with other colleagues such as our voluntary community sector, that prevents people tipping up you know, in crisis or as it happens as an inpatient. But I won't pretend there's an easy answer to this question. You could ask me about the community health side of it as well. It would be exactly the same answer. It is a challenge to recruit. We will continue. And as an outstanding organisation, we probably find it easier to recruit than some other organisations. But it is a challenge. So I think we have to think innovatively and differently about the career portfolios that we're offering to try and but it's a real risk. If we get 100% workforce, somebody else is probably missing some. So unfortunately, I don't have an easy answer to that, I'm afraid.
Thank you. And just to clarify that the actual role we've got in primary care is actually shared and hosted by yourselves at BHFT. So that brings primary care and secondary care working together with that role in an interface role. So we're not sort of robbing literally one of your staff. We are actually using your expertise, supporting that staff to make sure what they do in primary care is that extra quality than maybe that we would have had otherwise. Thank you very much.
Great, thank you. Sorry, I just thanks for that. I've got Councillor Alice Mpufo Coles. Alice.
Thank you, Chair. I just wanted to ask a question to Catherine about their strategy. Does it also include, for example, things like decentralizing mental health places to be in communities where, for example, given that they come to places like, let's say, community centers once a week, find somebody who can work with not specifically those mental health people that are very specialized, but somewhere where somebody can think, you know what, I can access somebody without even going to the GP just on a Tuesday. They come here and I can speak to them, those preventative measures. And when I speak to them, at least they can refer me to the right things and give me some tools also to work with, maybe about other things before things get really, really bad. Because we've noticed most of the community people don't actually go to the GP or the mental health place until it's very, very late. And yet they have seen the symptoms before in the community, and they actually don't know whether it is to do with mental health or it's stress or whatever they are going through. They can't define that until somebody just says, oh, maybe you're stressed, you need to be doing this and that. And then it prevents a lot of clouding into the NHS or the GPs and all that. Is there a strategy that can help with that?
Yeah, I mean, you're absolutely totally spot on, Alice. And that is, it is an aim that's already written into the generic sort of corporate 3-year strategy, but it will certainly be one of the areas of work in our mental health strategy. And it's interesting you give that example. So when we were in the sort of the peak of COVID, the exec team in BHFT were doing Teams calls with lots of different services. And I do remember a call with our mental health crisis team, and they'd actually found that because they were no longer literally situated in Royal Berk's emergency department because of COVID restrictions, and they were operating out of a community hall instead. They found that people were felt less stigmatized in terms of going to a community centre to meet the mental health team than the emergency department. So we certainly know that does work. It's not to say that we shouldn't always also have a presence in the emergency department, but it was certainly a very strong message that people felt more able to access our mental health services when it was just in a community base, because you could be walking in there for any reason. I didn't have, mental health teams sort of over the top of the door. So it absolutely totally is something that we want to do a lot more of. Thank you.
Thank you. Else indicating. So I suppose briefly, I'm also really interested in the development of the new strategy and how all parts of the community, voluntary sector partners and this board and the council are going to be involved in that. So if you want to briefly say something, what we can expect.
So what you can expect, so the way I always develop a strategy is I will start by looking at the current strategy, which is partly what we've done today. What's worked, what's not worked, and if something hasn't worked, why not? It might be, for example, IT sometimes is a little bit of a problem. Then if there's anything we want to take forward, so for example, basing services more in the community is in the current strategy, we'd want to continue that. But then scoping what else is new and needs to be included. And as you can imagine, we're often guided by national policies and directives. So we take all of that into account. I will then want to do a series of engagement workshops. So we have an overarching objective of having integrated community, physical and mental health teams co-located with primary care networks. But I would need to have conversations with primary care networks about what that actually looks like and what it in reality it means. Where are people going to be co-located? What sort of services are we going to put in those? So we would have some high-level ideas, and then we would need to engage with the right people about what that actually means in practice. Typically, we have a few conversations because you hone and refine things as you develop them. And then there needs to be a conversation about, okay, so we've got, for example, 10 really excellent ideas. You can't deliver 10 really excellent ideas in one go. So what will happen in year one? what might happen in year 2, what might happen in year 3. And again, we, as far as possible, that's co-produced. But there was always going to be something about managing expectations, because to be able to deliver services, for example, we need the workforce. So there do have to be, often has to be some level of pragmatism and prioritisation with all of this. So normally I would have had face-to-face engagement workshops, and I'd ask if I could have a slot on this meeting, for example, and share drafts. But now, of course, we tend to do that a bit more virtually, which actually does work sometimes better, because more people can be engaged virtually than they can, having to come along to a face-to-face. But we'll probably do a combination of both. And I'm very open to having drafts scheduled in on this agenda to give people an opportunity to input to that. So I hope that's helpful.
Okay, thank you. That does is helpful. Anybody else? In which case, thank you very much for bringing that, and so we look forward to development of the new strategy. Thank you. Okay, so we have Katie Summers. Katie, are you okay to go back to your items now, or do you need a little bit more time to prepared?
No, I've flown in. I'm very sorry, Councillor Hoskins, for coming in late to this meeting and such. So I'm happy to commence. Would you like me to commence with the actual overview of COVID vaccination?
We go back to COVID vaccinations. Yes, please. And then we also have, which actually be the next item, would be the Ics Development Roadmap. So yes, let's go back to the very important area of vaccination.
So I'm going to keep this quite brief, and I've got a presentation to share with you. But basically, this is just a quick update about where we are with the actual vaccination programme. I think it's fair to say across the country, vaccination uptake rates have significantly slowed down over the past month. And I think that's over a number of issues. It's to do with people's different focuses coming out of now the lockdown, and also some national messages. But we are now actually giving you some key updates about where we are as it's the moment. What I'd like to take forward at the moment in this update is discuss more about what's going to be taken forward as part of the actual spring programme, and also what are the potential plans also for autumn. So just to make people aware, the actual systems have been all working very rapidly in order to formulate our individual asks for spring. Spring is focusing on for both the children that are healthy, 5 to 11-year-olds, those children that are deemed to be clinically extremely vulnerable, which is that CV definition here, those people over 75 who require their boosters, and also anybody else. So this is in relation to anybody who hasn't actually already had their boosters. The actual spring programme for the over 75s and is actually kicking off on Monday, not from April. It's been taken forward this week till the 21st of April. And what that will be targeting is for those people over 75 will be encouraged to come in and actually visit either their practice sites through their PCNs, or they'll be going along and booking in via the national booking system to actually take up an opportunity of visiting a community pharmacy site or the Broad Street Mall. Now, also included in that group is also anybody who's in a care home, and also the care home staff, along with also housebound people, which also could incorporate also those people with learning disabilities, as well as also the immunosuppressed. The healthy 5 to 11-year-olds is kicking off actually on the 4th of April. So I'm just going to move forward. These are the individual sites that we're taking forward. So if you look on the screen, which is actually the on the right hand side, the actual healthy 5 to 11-year-olds, we had asked our individual sites PCN sites whether or not they felt that they could actually offer to do vaccinations, but I'm sure Andy Tchesky has already given you an update about some of the pressures that they're going on in primary care. So it's deemed actually it would be best to actually look at different sites. So we're working at the moment with pharmacies. I'm waiting for some pharmacy sites to be assured for them to be delivering 5 to 11-year-olds, but I'm sure at the next meeting we'll be able to give you an update about what sites they will be taken forward. Broad Street Mall is going to be offered out as well to do 5 to 11-year-olds, and they've now set up a fantastic site actually at the Broad Street Mall, which is incredibly child friendly. But we've also just, I'm delighted to say today, confirmed that we're also going to be actually offering it at the South Reading Community Hub. So South Reading Community Hub is going to be open as walk-ins. I will give you, it's all being worked out at the moment, but we will be releasing dates of when that site will be actually opened for walk-ups for any healthy 5 to 11-year-olds. On that South Reading Community Hub, also they will also be opening up for delivering any of that evergreen offer, so anybody will be able to walk in as well. So that's a piece of important note for you going forward. On the other evergreen offers, we have heard also from some other PCN sites that they felt that at the moment they would be unable to offer supporting continuation of evergreen as well as over 75s, and most of those are related to the central Reading areas. So what we're organising is ensuring that that South Reading Community Hub is actually centrally located to where we know that those PCNs or practices are no longer to be able to offer the actual sites going forward. On the autumn plan, at the moment, we know that actually most sites have said that they are going to be able to be continued to actually offer at the current time, offering a booster programme. But obviously, I think it's fair to say that most practices will review this over the actual summer period, and I think they will make a decision about whether or not to continue or not as it is at the moment. This is the current vaccination uptake rate. So basically in Reading, you're not doing too bad really at the moment. Your actual take-up rates from Reading PCNs, they're doing quite well. So you're at 76% for 12 age over for first, and equally you've got quite high rates for the flus, which is 79%. These are slightly lower from when the Berkshire West averages and where the Bob averages are. So again, we've still got to do some work in actually ensuring that we can get the major uptake for this. This is to do with the vaccination take up over time, and as you can see here, the flatlining of the actual information here. So you can see that there was a massive ramp up initially over the actual booster programme, but then from sort of January we saw a flatlining of the numbers. But again, this is probably to do with the fact that a lot of people now are feeling that actually they have had the vaccinations, and we need to provide further information about the importance of getting their boosters. I'm just going to rapidly go through this. So you've got some more information here about the take up, and these are comparables with your individual local authorities, and you can see here that actually your uptake rate is generally in the medium part with comparable local authorities, which is actually good to say, but we've still got to close the gap in relation to some other areas. Even the most areas that we've got to close the gaps is in relation to very much that younger population. So when you can see here quite clearly where it seems to drop off, so it comes to very much from the point of view of the younger populations of under 30s, where we definitely see a drop off in the actual rates going forward. This is uptake about the 12 to 15-year-olds, and we've still got gaps in, especially in relation to the 12 to 15-year-olds, but it's felt that most of these gaps are related to the fact that when the individual Berkshire Healthcare Trust school immunisation teams have gone in to do their visits, a lot of the children have not been able to take this up purely because they've actually had COVID. So again, we're going to organise a new visit going forward. So at this point, I think what we've tried to do in understanding about the challenges of Reading, I actually commissioned Health Watch in Reading to undertake a vaccine confidence survey. And at this point, I'd like to actually open the floor up to Catherine Williams, because I know Catherine is going to give you a really good overview of the initial findings of that survey. So I'll hand over to you, Catherine.
Thanks, Katie. So I've got a couple of slides to share with my short verbal update, if that's okay. Thank you. So I was just getting a bit of feedback there until Katie put her microphone off. So could you give me a thumbs up, Katie, if you can now see my first slide, as I can't see anything else. Thank you very much. OK, so as Katie mentioned, she's commissioned us at Health Watch Reading. I'm Catherine Williams, a Health Watch officer at Health Watch Reading, to do a short poll that ran for a couple of weeks in February, just to give a very brief snapshot of why some people in Reading are choosing not to have vaccination, not feeling confident about it for some reason. And also at the same time, she commissioned us to do some social media dialogues with people on Facebook to see if we could get some more in-depth qualitative information, again, to inform that snapshot. And as Katie said, we're still in the process of completing the overall analysis, particularly of the qualitative, as you'll see in a moment. We had a lot of comments there, but this is to give this board some further information to supplement Katie's report that she's just given. Really interesting findings, I think. To tell you what we did, it was a really short poll online, 3 questions and then 3 additional questions to give some demographic information to hear what's behind your personal choice not to get vaccinated. And the poll ran initially for a couple of weeks in English while we were getting it translated, and then we restarted it again so that it ran for a total of an additional 2 weeks, with 6 community languages added, the poll translated, and the languages were chosen so that they reflected particularly those communities where we know people, for whatever reason, are not getting not getting vaccinated in such numbers. We promoted the poll through a whole range of channels. The council had it and promoted it and were very good at tweeting it as well as putting it out through your other channels. I personally contacted 15 community organisations in Reading. We got a very positive response, particularly when the translated version of the poll came out. People were sending it out through their channels, email, WhatsApp, Twitter, and so on. And then, as I say, additionally, we ran some social media dialogues. We were promoting on Instagram, but most particularly, we ran some supported conversations on Facebook. And on this slide, sorry, it's quite busy, but the idea was just to keep it to the minimum number of slides in this short presentation. You can see some of the figures coming through. So we had a total of 437 people, we think. We're just weeding out any duplicates there were, but we think 437 people gave views, and that includes 277 comments that we got on Facebook, as well as 160 responses coming in actually formally answering the poll questions. And 5 of those came in from Reading Refugee Support, who ran the questions separately through their own network to see what answers they could generate. We found that in the poll, the highest number, so this is, remember, it's people responding, are people who for whatever reason have turned down one or more opportunities for vaccination. It isn't a general population poll, it's for people who for whatever reason have said no at some point. We had 81% had said no to the first dose, 57% no to the second dose, and 69% said no, I haven't had a booster. You'll see that of the respondents, it was roughly 2 to 1 women to men. 78% are white British or other white ethnicity, 12% from other ethnic backgrounds. I'll come back to that point. Age clustered in those groups where we're actually seeing in the vaccinations data that Katie presented, people are perhaps not coming forward. So the main groups there in the range 25 through to 54, with the biggest cluster in the middle in the 35 to 44 age group. Now, here's the interesting thing. The top reason in the actual poll, the answering the questions that people indicated, and you could tick all that applied, the top reason that people said was why they'd not come forward for one or more vaccinations was concern about the side effects. In total, about 83% included that in their list of reasons. Also scoring highly among the reasons were the belief that COVID is mild and the belief that you're covered once you've been infected once. And interestingly, 70% said nothing would change their mind. And we did offer options, including, would a further conversation with a healthcare professional assist? And that scored quite low because we were trying to sound out what might make a difference. And we got very similar comments from the dialogues on Facebook, some really rich information coming through there that we're looking at currently in the analysis. Quite a lot of concern again about side effects and so forth, and some conspiracy theory type comments as well, perhaps fewer of those, but some really quite strong comments there amongst those. And as I say, we're currently analysing to put that into a full report. And I've given just one example of the many comments, somebody saying 2 members of my family contracted stroke after they had that jab. So in summary, and I will stop sharing my screen. There we go. So in summary, we'd heard from over 400 people. The findings are interesting, but coming back to that point about the ethnicities that we'd heard from, it's so important that we do hear more from those communities with lower rates of vaccination, and that's why the Reading Borough Council vaccine champion scheme that we heard about earlier is so exciting. We're involved with that along with so many other organisations in Reading, because what's clear from this, as we discussed at Vaccinations Action Group when the poll was being raised, and Katie commissioned it from us, we do know from past experience that the way to reach communities in Reading is to go out and speak to them one-to-one. And when I spoke to Victor at ACRE about the selection of languages for the poll to back up the data that we had from the South East vaccinations data poll information that Katie had to inform which communities were hesitating to come forward, perhaps, he did emphasise to me as well, it's so important to go out and actually speak with people about what their reasons are. Yeah, so that's the end of my presentation. Thanks, Katie.
Thank you. So this actual survey is a really informative one, and it's really good that actually we got Healthwatch support to actually understand that. And I think it really does give us the messages out there that actually we've got to go out, but also taking what Catherine McDermott had said earlier on from the findings when they went out from mental health services, demystifying, but also going out and actually delivering services where local communities feel that they're not going to be stigmatized is a key thing. And actually, I think sometimes when it comes to vaccinations, especially from those people that are either seldom heard or they are just very, very cautious of vaccine hesitancy, they tend to be grouped. And some people might not want to go into a certain centre purely because they might be seen as such. So going into some community centres, like I was saying, so South Reading Community Hub will be a really good opportunity for us to try and actually get more people to come through.
Okay, thank you. I have someone indicating, but I can't see who they are until I... It's not showing. It's not indicating because it's sort of, hang on, I'll find you. Oh, sorry, that's why it's someone waiting in the lobby. Right, okay, thank you very much for that. I mean, I think that was really interesting, particularly the Healthwatch work done. Some of it really challenging. So quick question. I know you said about you know, the 70% who say they'll never change their minds is obviously a concern. Obviously, the side effects is clearly a major element of people's concerns. You said that would speak to a health professional help, which was sort of a no. Was there any indication in terms of was there other, you know, what would be the most effective? Who would they perhaps they trust and listen to? Was there any sort of information on that coming back from the survey?
Thanks, Graham. I think I can't say off the numerical data that I'm looking at, but with a colleague, I'm looking in detail at the qualitative data, and that's going to inform strongly the written report that we're writing up over the next couple of weeks. And that was obviously part of what Katie was commissioning for, that we see if we get that additional in-depth information. But I can't think, from having sort of read through the qualitative once, and we're in the process kind of coding it. I can't think there was any one thing that jumped out, but okay. take that as preliminary.
Yeah, hopefully it'll fit the Champions programme, and that will.
Yeah, and I think that's going to make all the difference. Thank you. Yeah.
And thank you, Katie. Anyone else? I haven't got anyone else indicating, so thank you for that. I think that's really helpful. Should we move on then to the Bob Ics Development Roadmap? Katie.
Yeah. Councillor Hoskin, I won't share my presentation because otherwise you might have death by presentation. I'm just very conscious that actually at the last meeting you actually had Dr. James Kent come along and give a really detailed update about the creation of the Integrated Care Board. You've got the actual presentation included in there, and that actually sets out very much the individual roadmap that is being created now in order to support the actual development of the Integrated Care Board. And I think it's fair to say at the moment, over March, a lot of the activities that have been going on has been the creation of that individual roadmap, but also listing out the individual transitional activities that are supporting an overarching system delivery plan, an SDP. Now that is going to be updated as such, and that is supporting us with regards to what we've got to do as a CCG to reflect how we are now expected to now carry on for another 3 months before the actual white paper is signed off and the ICB is in their statutory footing as such going forward. It gives a bit also updates about what's going on in relation to place-based partnerships. So you've got some inclinations there about the individual key functions that are actually going to be considered. So I would actually say that moving forward, I think health and wellbeing boards will form part of a really good piece in actually being part of that individual place-based partnerships. Your actual work in that was going to be really quite critical. What's going to be taken forward in there is the fact that the ICBs will, as part of their system development plan, organise a way of actually testing out what delegated functions, as well as also finances, would be actually delegated through to place-based partnerships. So now with place-based partnerships is a real key focus, I would actually say, because understanding about what types of delegations should be given down to place-based partnerships is quite the critical one going forward. I'm happy to take any questions, but I feel the update that James gave you last time was actually probably the most informative one. And today it was very much just saying it's a bit of a transition period. When we next get together, which will be in May, yes, May, that will be I think you'll have much more details about what's taken forward with regards to structures of the ICB, names of people who's taken forward, as well as also further updates about what's taken forward for the place-based partnerships.
Yeah, I mean, certainly the last meeting, the importance of representation at the ICP of the ICP, but basically at that Bob level by the council was something that's important. Representation's been made. My question, I think, because I think it's really important, and you may or may not have sort of details, but it's certainly something you want to get to grips with, is that of place-based partnerships. It's really helpful in terms of seeing it written down where we're at. It talks about formally establishing Committee of Integrated Care Board, initial delegated authority, and establishing governance groups. So it's establishing those governance groups and the role of local councils in that. Particularly because our place includes 3 local authorities. It's not going to be a simple process to establish the governance arrangements of that. So it's the sooner we get onto that and we get that common buy-in, as well as understanding the delegations down, I think would be really important. I don't know if you've got anything to add on that.
No, I must admit I've been speaking directly with Belinda Seston, who at the moment is the interim programme director as such, about this, and I've said we need to be raising this through the Berkshire West Unified Executive, but equally I feel that there might be a need to actually have some form of workshop that brings together the chairs of the health and wellbeing boards, as well as any other representatives that they would see fit to come forward with, in order to co-design and co-create those individual governance structures. Because it's, as you say, Councillor Hoskins, since I've been doing this role across all 3, you're all very different. You all have different structures, you all have different governance routes, and so we're needing to actually map this all out in order to ensure that we have a streamlined but equally co-designed, co-inclusive approach, I think, going forward. So I've made that very clear, and I think I will touching base with Catherine about this and speaking with Julie and Ems, I think would be a really good opportunity to take forward.
Okay, thank you. That's I think that's helpful, and you do that. There's no point rehearsing some of the things or rehashing some of the things we said when James came last, and hopefully we'll get him here again where we're at in July. Haven't got anyone else indicating, in which case, Katie, thank you very much for joining us. And I think this is possibly your sort of hurrah. You're off to be working in Cornwall. So I don't know if you're going to. Well, yeah, I don't think you've got any more items, so I just want to say thank you for your contribution and candid, the candid contributions in your hard work, particularly over the pandemic stuff and the vaccinations.
Oh, thank you, Councillor Hoskins. I've really enjoyed the opportunity of taking up and working in Reading. I would actually say, as a health and wellbeing board, you are a really good setup. Your governance structures, your partnership workings clearly are actually making a big difference in Reading going forward. It's really delighted to hear that actually you've got the opportunity of doing some of that COVID champion work, and I think that's going to make a big difference. I think it's going to be a very exciting time for Reading with the white paper, and equally with any white papers in the actual social care arena, and actually seeing how that actually all progresses. Obviously, I've moved down to Cornwall in December, so I must admit I'm going to be taking some of the learning down to Cornwall, where they have it's a very different makeup there. They have huge amounts of deprivation, but it tends to be very much occupational led deprivations as opposed from cultural deprivations as such. So it's going to be a very interesting time, but I've really enjoyed working with you all. But thank you.
Okay, thank you. Nice words, but yeah, good luck. All goes well. Okay, thanks for that. So we talked about the ICP. We've got Andy Czerski, an update on the ICP Unified Executive.
You've had far too much of me today, Chair, but the last hurrah from me for today, hopefully. So yes, an update from the ICP Unified Executive Chair's reports for January and February. I'm not going to read out the papers, but just give a few highlights of the sort of discussions that take place at that Unified Executive, which may well become in the course of time where the place-based partnership discussions take place, as we have our health and local authority partners sitting together there. So just a few highlights of talking about connected care. I think I mentioned connected care earlier in the meeting. It's been a transformational lever for use in Berkshire West, removing duplication of effort. It's been the way to have a partnership health and care shared record for our residents across Berkshire West. It's actually also stretched into Berkshire East and the Frimley system, and one of the ambitions is, as we go into the new ICS structures with Bucks and Oxfordshire, is to sort of promote some of the learning and supporting them in similar sort of integrated working and sharing of a shared care record. I think there is something there's an Oxford sort of healthcare record, but it's been done in a slightly different way. Some of the, just for information, some of the usefulness of using the system is using it for monitoring patients for blood pressure monitoring at home. The long-term condition program supports that. Another one that hasn't been mentioned in the paper is oximetry at home for monitoring our patients, high-risk patients with COVID, giving them oxygen saturation monitors and monitoring them. So having a central database for those patients, both in targeting patients, finding out who might be at risk, getting in touch with them, and then putting them into a virtual ward and monitoring them is the way that connected care has been able to support that. So that was important. I won't talk about the health and wellbeing strategy because that's been mentioned today, but it was discussed at the Unified Exec and was being popularised with all the leaders by the public health team, and how important it is to underpin all the strategies that in the healthcare system, and that the health wellbeing strategy should be at the forefront of everybody's thinking in any strategy that they're dealing with within their own organisations. There was some discussion about the Better Care Fund in January as we were coming through winter. A lot of pressure on the urgent care system, and there were discussions about how the Better Care Fund supports the sort of prevention, avoidance, and support of generally the urgent care agenda. And the BCF has been established for some years. There are specific programs that it helps to fund, and I think there was just a discussion amongst leaders to have some transparency and clarity about, you know, what services are being delivered, what are the levels of investment, and what are the outcomes of the BCF projects. I think those come up obviously in a lot of our discussions, but it's a matter of just sharing those with leaders from other organisations. Moving into the February update, we talked about the ICS just a moment ago. Somewhere in the presentation, which wasn't shared on screen, but I've been looking on. I've got double vision on my screen, so I can see the presentation in one eye and yourself, Graham, in my other eye. There's a mention about primary care representation, and the chair of the Berkshire West Primary Care Networks, Dr. Amit Sharma, presented what the GP structures may look like. There was a big programme of work done in conjunction with the Buckinghamshire and Oxfordshire GPs, and using the local medical committee, the LMC, and they've come out with a proposal of what the structure should look like to represent the primary care voice in the new ICS structures. What some of the work going forward will be to socialise that with our primary care members, getting a clear mandate from them that they agree with this structure, and so that we have a strong voice for general practice going forward as the ICS takes over on a wider geography. There was a quick update on a project done by McKinsey's on the activity flows in hospitals through the pandemic. We haven't got quite all the information coming out of it, but there was a definite shift in the way activity was happening in hospitals, and the economic implications of that. So I think there's going to be some work being done on how all the acute hospitals and all the beds that are used across our community can cope with that. And as an extension of that discussion, the hospital discharge service, which was sort of funded through the pandemic nationally, and was crucial in keeping a flow of patients through hospitals, using both the acute community teams and the social care teams to make sure patients could be discharged with a timely manner into the right sort of care that they needed. Unfortunately, the national funding for that doesn't continue, and the implication is either we find that money locally, or we find ways of doing it by efficiently, hopefully offsetting costs which would have otherwise been incurred if we didn't have that model. So it's a very difficult discussion, and one that is ongoing at the senior leaders level in the ICP. And that's about it, really. There was a last bit about social care funding and nursing bed strategy. This is a long-standing piece of work about how health and social care support patients, residents really, who end up in a nursing bed. And there's a new programme which unfortunately halted through COVID to try and get this up and running, to try and improve the work that goes on and improve the care of these patients. So there may be something more to report in future reports. Thank you.
Great, thank you, Andy. Really interesting to hear about the BCF stuff. We so get it here. We assume that it goes in various different directions. Of course, that's not necessarily the case. So obviously need to maybe the item about standing members of the two provider trusts being on this board may help part of that structure of reporting around the BCF, but certainly something to think about. Anyone has on that? No, I'm not seeing anyone. So thank you very much, Andy, for that update. We shall, as we were talking about BCF, move straight on to the integrated integration program update, including the BCF. Bev Nicholson, are you here with us?
I am here. Thank you very much, Councillor Hoskin. Good to be here, and I'll share my report. Hopefully everybody's had a chance to read the report, so I'm not going to go through it in every detail, but I will just give the highlights if that's okay. So obviously the purpose of this report is about demonstrating performance against the Better Care Fund metrics, which are national metrics, and they were amended in the last round of planning. So those metrics have come in since the Q3, which is October, November, December. So we achieved 3 of the 5 Better Care Fund targets. They were the avoidable admissions and people discharged from hospital to their normal place of residence, and the number of older adults whose long-term care needs were being met by admission to residential or nursing care. Those that we didn't meet were the length of stay. So there were two elements to the length of stay target. There's 14 days and 21 days. And for those over 14 days, we missed the target by 1.2%. However, there's a national aim for that target of 12%. So even at 10.7%, we're below the national target for that. So, you know, it's not all doom and gloom. The 21-day target, we were 1.1% away from meeting. And these tend to be the pathway 3 more complex cases that tend to be longer stayers. So it takes a bit more time to arrange appropriate care for them. The other target that we missed was the 91-day target. So that's for people remaining at home following discharge from hospital. And we're looking at the September cohort of patients being discharged into the reablement service. Now, as I've mentioned before in these meetings, we are required to include people that were end of life but were referred into the reablement service. And had we not included those people in the figures, we absolutely would have exceeded the target. But we are improving, and we were 5% away from that target. And sadly, we had 5 of the 6 people that weren't still at home at that assessment date had passed away, sadly. So we're working with our system partners to really try and identify those end-of-life pathways appropriately and make sure that people get the right referrals. So I'm just going to whiz down to some of our performance data. So I've got charts in here so people can see the detail behind those statistics. I'm going to have a look now at the local targets. So these are funded through our Better Care Fund as well. So looking at, sorry, it's being a bit slow. So we have a facility at Charles Claw Court for what we call step up, step down beds. So this is a discharge to assess facility. from hospital. However, we found with those flats that they're not really working the way that we were hoping that they would work. And we understand the reasons behind that, and we're working now to develop a new service that would take on the learning from this. We have some very complex cases in those beds, so it's been a bit stuck and people haven't really moved on as much as we would have hoped. We have an alternative discharge to assess service now running at Huntley Place, in the short term for now, and we are talking about potential funding going forward and how this service possibly could be continued. This model is a therapy-led service, so it's a 10-bedded service at Huntley Place, and it really has had a positive impact in the short term on hospital discharge flow. So that's really been effective. We haven't seen as many cases going through our community reablement team service, but we are looking at the metric for this because we believe it really should be measured in hours rather than numbers of people, because of the sometimes double-handed care packages. However, the average length of stay of people going through this community reablement team was 3.25 weeks against a maximum target of 6 weeks, which is really positive. They're turning people around quickly, and actually the feedback from service users is 100% satisfaction, which is really positive. I'm going to move on now to some of the key projects that we've been promoting through the integration board. So one is the multidisciplinary teams grouping, and we have now got 3 MDTs running across primary care networks, and they've been clustered into 3 groups. So we're focusing on themed discussions at these meetings, and these themes will be adjusted as we get through the cohorts that are assessed for discussion at those multidisciplinary team meetings. And it's been really positive. We've had some positive feedback from our primary care colleagues, and we're hoping that this will continue to grow. We've certainly seen some increased numbers of people being discussed at the MDT meetings. The other key projects that we had, there's just some information there about the Huntley Place setting. One of the other projects that we had was the Nepalese Diabetes Project. That again has been really successful, achieved positive outcomes, and has now been rolled out to 2 further GP practices within the area. We're still awaiting the detailed outcomes of that first cohort. However, the project lead has reported that there have been some really positive impacts of the programme, and it's also enabled people in this cohort to manage their conditions much more effectively as a result of what they've learned within those dedicated sessions. And again, addressing health inequalities has continued to be a theme throughout all of our programmes within the integration board. And the board is also leading on priorities 1, reduce the differences in health between different groups of people, and 2, supporting individuals at high risk of bad health outcomes to live healthy lives from the Health and Wellbeing Board joint strategic priorities. So the board have been working on those action plans, and I know that was presented earlier by Amanda. So we're all very much engaged in that piece of work, and we'll continue to consider those health inequalities across all of the priorities that we're setting for the future. And we're working with our local system partners to support a delivery of a range of activities to address those priorities. So I think that's my highlight report. Does anybody have any questions they'd like to ask? I'll stop sharing now because that's a bit busy with the screen.
Thank you, Bev. I've got 3 people indicating, and looks like this is a new and very helpful facility on Teams. I can see the order, which I think means I've got Shona Douglas, then Katie Summers, and then Councillor John Ennis. So, Shona.
Yeah, thank you, and thanks, Bev, for the report. Because I suppose what I just wanted to highlight, is some of the kind of work about outcomes for some of our residents, and I think that quite often I know that these kind of submissions get tied up with the numbers, but actually some of the outcomes are really, really positive. And I thought it was just a good point to pick up the Charles Court and discharge to assess, because the model's the right model in terms of what we were trying to do was stop people going into care homes from hospital and trying to kind of immobilise them in extra care in order to get them back home. The dilemma about why it hasn't worked in Charles Court as successfully as we would like is that that traditionally there's people who've been Charles Court in the extra care there have been quite long stayers, and people who've gone in and discharged to assess haven't wanted to go back home because it's felt like a very, very welcoming environment. So that's the right thing, but obviously freeing those beds up has been really important. So that's why we've shifted the model to Huntley Place, which is working much more effectively, and it's probably that Charles Court is probably a better environment for extra care for people going there and staying there, and that Huntley Place is better suited to places where they can be mobilised, and it's a newer service. It's got bigger rooms, we can get people mobilised with equipment and things more easily in there. So I suppose I just wanted to flag that in terms of the model with outcomes, because we are completely committed to keeping people out of care homes and getting them back home or staying in the communities independent as they can for as long as they can. I think one of the bits that we're kind of just having to kind of look at is really about how we get the financial resource in order to support that, because whilst it's an element across health and social care, and obviously we're going to need to kind of have some discussions between ourselves around how we fund that, because that has benefits for both health and social care going forward in the future, given that model. So that was the other issue. I suppose it was just worth highlighting is around what, and I think Andy's referred to it as well in what he was saying a little earlier, is some of the dependence levels that we're seeing. And what we're trying to do is we've had a lot of care packages coming out of hospital that have been 4 calls, 2 carers 4 times a day, and that's a very heavy package. And what we've been needing to look at is really what's the viability of that, and are there other types of services and other tech solutions that support that encourage independence rather than dependence. And it is a very fine line sometimes around those differences. But I think that's work we still want to do, because it's evidently really good for people's outcomes to be independent for as long as they can and be back at home. So I thought it was just it's worth kind of highlighting those areas in terms of what difference does it make to residents of Reading.
Great, thanks. Right, Katie Summers.
Yeah, so building on what Shona was actually describing there, you talked about the reablement patients, and actually rather than using as the numbers, using an outcome base. So Shona, I presume the reasons why the number of patients is to do with the fact that actually you're just having to do those doubling up or quadrupling up, so you haven't necessarily had the capacity in order to actually get through those patients. Is that, I mean,
what it does, it doubles up the capacity, doesn't it? That's the kind of issue.
I think the thing is, it's actually how quickly we need to monitor how quickly individuals are actually almost like institutionalized when they go from home into hospital and then they're coming back out again. A bit similar to what you were saying about the actual discharge to assess models. So this is exactly the same pattern actually happened in Wokingham. They got too comfortable and they didn't want to move on. So it's actually assessing that risk of, I hate using the word, but the only way I can describe it is that institutionalized type of approach, and that's got to be almost like assessed before they're actually even considered to be put into a discharge to assess model, I think, going forward.
Can I respond? I think the challenge is because stuff moves so quickly and we need to act so quickly, we just haven't got the time to do that. Because actually people are coming out who are very sick, and we're not able to undertake the really kind of rehab focus sometimes for 2 weeks into following discharge. And that's one of the challenges. I guess that one of the things that we're thinking, I mean, we're restructuring adult social care into the primary care network so that we've got locality teams across the PCNs, so that we have team managers and seniors that relate to those PCNs and they know who they are, the doctors know who they are, and we get a much better service. Because I think that there's a lot of work we can do with our PCN colleagues when we're in a kind of, and the multidisciplinary teams is the kind of bit that kind of is that, but I think it's about building those relationships at a locality level that people get to know each other. So, you know, the doctors and the surgery staff know that it's, you know, Bev is the team manager, and they build that relationship as opposed to what we have at the moment. So that's partly our design of trying to put it, because I think they're the issues that we can use the GP kind of knowledge and the district nurse knowledge to help us with some of that. But things move so fast, Katie. It's been really hard. A lot of people are very poorly and not able to benefit from the service, at least some 3 weeks into discharge.
To what I'm showing, I completely understand that, and actually there is going to be coming out quite soon a new anticipatory care model. So describing, Shona, what you were saying there about redesigning the adult social care teams to align to those individual networks or clusters is actually where I heard on Thursday evening what the anticipatory care models are expected to be taken forward with. So actually you are doing exactly what the NHS is wanting to see, and I think this is also going to be coming into very much from the point of view of the adult social care arena as well. The other question, Beverly, I had was about end of life care, and we might want to take it offline, but actually is Sue Ryder actually commissioned by the Better Care Fund?
No, Katie.
No, it's outside of the Better Care Fund. That's what I thought. So
yeah.
That's fine.
Yeah.
Okay.
Okay, thank you. Right, John Ennis, Councillor John Ennis. John, all your names.
Yeah, thanks for letting me. I'm John Ennis, Lead Councillor Adult Social Care, introducing myself at 1640. Yeah, I think it's a really good report, some really good work going on in unprecedented times, really, between the hospital and adult social care in Reading Council. My question is, of course, the challenges are going to only continue, really, with the hospital legitimately trying to open beds and feeling the pressure of trying to discharge patients who wouldn't I use the word normal times, under previous times, who would probably stay in hospital, who are not yet fit, and then you've got a council that's under unprecedented financial pressure to ensure that they got the right packages to support the right people, and it's value for money, but also quality of care. And I heard about Giles Claw, because I know anecdotally some people are finding it a good place to go, actually. It's not too bad for them. There's 1 or 2 contacted. It's going on from there to permanent accommodation is the problem, or one of the problems. But I was going to say, with our health colleagues in the hospitals, we'd need to work together, wouldn't we? And how that would happen going forward. What's the position going forward with that to ensure that both legitimate concerns of the hospital being able to discharge and the council being able to sustain the care packages that are being placed on them? I don't know what the view is there. Thank you.
Yeah, thank you, Councillor Ennis. And obviously the model that we employed at Huntley Place was very much therapy led, which was a difference between that and Charles Claw Court, and perhaps that's why it's been so good at moving people on quickly. And that's been a really good outcome for people to be able to move back home in that much quicker time frame. And we are looking at ways of being able to fund something like that going forward, but it very much means that we need to work with our system partners to be able to do that, because as you say, there are challenges on the budgets for everybody concerned. It's just about getting the better outcomes really for people. At the end of the day, that's what it's all about, is making sure that we wrap that care around them and enable them to really get back home with the right support that they need to carry on. So thank you.
Great, thank you. Anyone else indicating? So thank you very much for that. It's particularly useful to get the the narrative around the impacts of the work being done was always really important to bring ourselves back to. So thank you very much, Bev, for that. Right, we've got the two dashboard reports. Kim McCall.
Hello.
Yes.
Yes, so two dashboard reports today. So the first one is the outgoing health and wellbeing dashboard, which is reflecting the priorities from the sort of outgoing health and wellbeing strategy. So this is the dashboard that you'll be used to seeing every quarter, and at the beginning of the report you'll see a list of which of the indicators have been updated in this quarter. I think what's possibly the most interesting thing to point out about these ones is that while some of them have been affected by COVID, so for example, the dementia diagnosis rate is still lower than it was pre-2020. It hasn't quite recovered, but our position in relation to the national average hasn't really changed, and that's the same for certainly for these indicators that have been updated this quarter. Yes, unless there's any other unless there are any other questions on what the rest of the contents of the report, do you want me to go on and talk about the next report, which is about the development of the new health and wellbeing dashboard reflecting the new priorities? Yep, shall I move on? I mean, I'm happy to obviously take any questions if any.
I think that's fine. Yeah. Go ahead.
Thank you. Yeah, so the next report is just outlining where we are with developing the new dashboard, and I think you'd have heard from Amanda earlier in this meeting talking about the implementation plans and how they've been developed. And as we've been doing that, I've been sitting in with the leads and hearing about what they're how they're addressing the priorities in the strategy, and we've been trying to capture ways that we can capture any change or progress on those priorities. And what you just find in that report, what you'll find is we've outlined some of the ways that we think we might do that when you get the dashboard report in July, the first dashboard report in July. So I think an important thing to mention, some of the feedback from the board was that so the previous dashboard, the one we've just looked at, relied quite heavily on nationally reported what is now OHID indicators. Lots of those are based on sort of survey data. They get refreshed annually, most of them, some of them less frequently than that, and they tend to be quite slow moving. They're sort of outcome focused really, and yes, so things like overweight and obesity, life expectancy, things like this, they don't tend to change very quickly. So we look at them every quarter, but they don't get refreshed every quarter, and you're unlikely to see that much change even year to year really. So some of the feedback from the board was that the new dashboard, we wanted to include some local, maybe slightly more activity data, so we can know a little bit more about some of the work that's going on to support the different priorities. So that's something that you'll hopefully see in the report next time. Yeah, was there? Did anyone want to ask me anything about the the current dashboard or the new dashboard, or what will be reported next time?
Thanks for that. It's a nice overview. I can't see anybody, which is like really helpful to understand. I mean, I'm not quite sure how I feel about the fact that whilst we might be struggling to meet targets, everyone else is too. I'm not sure. That's sort of like, not sure how I feel about that, but it's useful to understand the context.
Yeah, I think it just tells us that so the issues that we're seeing aren't down to how those services are being managed or run. It's just the sort of difficulties that people are facing everywhere.
Okay, thanks. So in terms of, so people, you know, it's late on a Friday afternoon, people may be, it's been quite a long meeting. People may start to have thoughts around the dashboard as they go over the weekend. You know, what else would you be thinking about? It's best to feedback to yourself on that if members of the board have that.
Yeah, that would be lovely. Yeah, and we're having a meeting with the leads for the implementation plans as well. So I'll be able to sort of feed that back to them and how we might report on different priorities. So that'd be great.
Great. Yeah, I mean, it's yeah, we need to think further. There's a challenge between, or there's a tension between hard data, which, as you say, can be a bit centrally controlled and slow, local stuff, which sometimes can be, you know, having that as the same sort of hard data can be challenging as well. So again, that balance will be.
Yeah, I agree. There's a balance to be had between understanding the sort of contextual information, what the sort of overarching outcomes are, and what are we actually doing, and are we doing what we said we would do.
Lovely. Thank you very much. Sorry, nobody's saying okay, it's not. This isn't important. I love the dashboard, but yeah, no, thanks for the update.
Lovely. Thank you.
Thank you. So the last item is a proposal for the Royal Berkshire NHS Foundation Trust and the Berkshire Healthcare NHS Foundation Trust to have standing membership of this committee. Lots of people may imagine that they did already and have been coming along to meetings. This is formalising it. I don't know. Shall I present this, Nikki? We haven't got an officer, but I'll go through the recommended actions. A bit of historical context. When Health and Wellbeing Boards was set up, there was very much a sort of provider-commissioner split, and the NHS kind of wanted it that way a little bit. And that's moved on. I think we're in a much better place in terms of partnership working across the board. So I certainly welcome this, and I think this is something we should have done a little while ago. The recommended actions there are that representatives be co-opted as non-voting additional member. We don't really have any experience with this. I think the voting element is important either way. And co-opted on here, and the relevant amendments goes in terms of reference and powers and duties of the Health and Wellbeing Board are agreed. So I think that's relatively straightforward, and I think it's a welcome change. I don't know if anybody has anything. I suppose now's the point. If you don't agree, please indicate. I haven't seen any indication, so I'm hoping that. Oh, Andy.
As your vice chair, I was just going to completely concur with what you said and totally agree, and because I knew you wouldn't have anybody saying otherwise.
Well, I like to take silence as agreement. That's certainly how I. Yeah, no, that's great. Thank you, Andy.
Yeah, right. You have at least one positive voice coming back to you.
Well, some people might be saying, "Why did it take you so long?" But it's like tidying up, I think, the way we've been working a little bit. Okay, that's great. That was the last main item. As Nikki keeps pointing, or will point out to me, that the date of the next meeting, and I've on a piece of agenda I can't find, is the last
15th of July.
Great. So thank you, everybody.
Chair, technically, you're actually agreeing the dates for the year. Just
is there more of that? Sorry, I've lost my last page of my agenda, so flying blind now.
Yeah, you got 4 dates for the year. That's just up for the board to agree. We put it in the planner, but the board needs to just formally agree them because you're a partnership board. You're not technically part of the council, so.
No, that's really important, and they are. Hopefully, everyone's seen them. So they're both, dates in October, January, March. You should see them on your agenda item. Right. Oh, contributors got Tracy Dashkovich is indicating.
Just a quick AOB. I don't want to keep people.
Oh, okay. Oh, we don't. Do we have
AOBs?
AOBs? Right. Okay. So we've agreed the dates. Hopefully, no one's demurring. So right. Shall I? Yeah. Okay, Tracy, I'll allow it.
Sorry. It's just to say there's been conversations in various arena over the past week or so, as you'd expect, around our imminent arrival of people from the Ukraine and what we as councils and NHS partners will be doing to welcome them. It's just to put it on the agenda really, and obviously there'll be something that we could possibly update on at the next meeting. It is just conversations at the moment, nothing has been formalised, but I am expecting that we will need to put in similar systems to what we did when we received guests from Afghanistan. The challenge that will be with Ukraine, which will be different from Afghanistan from a health point of view, was things like health assessment, update vaccinations were done in the inboarding hotels, whereas Ukrainian visitors are more likely to be more dispersed over our population with the way that they're being housed. So it is not going to be as easy to do that. We're not going to have a centralised effort with that. So we're going to have to think about as a system how we do get health assessments, vaccinations and healthcare and registration with GPs to people as they arrive. We're expecting people into the UK as early as Sunday and Monday, really. So I think it is a case of it won't be quite as much of running to catch up as we did with Afghanistan, because everything with that happened so quickly. But I think we will have quite a busy week. Katie, did you want to add from your world perspective?
Yeah, so Tracy and I have been sort of liaising about this today, and I think what we're going to try and do is actually look about how we coordinate this response as a place-based partnership. But then equally, I'm very much building what Tracy was saying is we need to support the individuals that are coming through also, not only from doing their vaccinations and health checks and things. These are going to be very traumatized individuals. We don't know what their health burdens are. We know actually Ukraine, they tend to have a lot more health burdens. So I think what we have to do is have a wider conversation as a local place to consider the individual risks that are going to come about as part of this. And because as Tracy was saying, it's a very dispersed model as such, we're going to have to ensure that we have a very wide group going forward. So I think what we'll do, Councillor Hoskins, is actually give you further updates as things evolve going forward as such. Is that fair, Tracy?
Yeah, I think so. And there are various conversations. I know that there are groups being, all councils are having internal conversations about this. I've been part of conversations in 3 different forums this week and very different meetings. So there's a lot happening pan Berkshire, there's a lot happening from an NHS perspective and a lot happening from individual and collective local authority. So there's a lot of conversation. I think the job now is to organise it so we're all facing in the right direction and not duplicating, which often means that some things get missed out. Because like Katie says, it's that layers. There's the immediate health, there's the screening of long-term health, things like TB, for example, and that more difficult thing to deal with, which is incoming and ongoing trauma. So it's about how we have all those things in place, as well as practicalities as warmth, shelter and food.
Okay, thanks for that, and thanks for raising that, which is a really important challenge for us coming up. I think actually my personal feeling is that there's real opportunities in it being less centrally controlled. I think some of the problems we had previously were something like the Home Office contracting system sort of failed in some ways. So I realise that there's other challenges about how this will work that we'll work through. But I feel that we're locally in a better place in some ways to meet.
You'll be delighted to know, Councillor Hoskin, it appears the government are doing a full over to you.
Yeah, well, that's the other thing. I was about to say they wash their hands. I was about to say they wash their hands and don't provide sufficient support and resources to communities to deal. But yeah,
we won't have the heavy hand of the Home Office this time.
Yeah, we just yes, exactly. Give us the resource and we can do a better job. But I would say that. Alice, you're indicating.
Hi, thank you very much for that about refugees. One of the things that has been recently raised is the language barrier when it comes to refugees that come with children. For example, one case that I know is about young people who have just straight when they arrive, they go to school and then they more or less go back to the hotels, and they're having difficulties with everything, and getting very distressed and sort of depressed, and the moms are have no idea what to do with the young people going to the schools, and getting very sort of the symptoms of mental health starting at the same time, because the mom and the child are also struggling at the same time about the language, and they're not sure whether this is mental health or anything to do with something. How are we planning to sort of, because already in Reading there's refugees who are there in hotels, and how are we planning to help, because we're looking at double trauma here, people becoming double diasporas in a sense, and all that. How are we planning to help specifically things like that?
If you're happy for me to answer, Councillor Hoskin, I think we've done a lot of learning from the people that arrived from Afghanistan, and some of the challenges we had with there was a lot of work done very naively around things like producing written material in multiple dialects. Of course, the dialects are multiple, so it's not just about one language. That offset with low level of literacy, so it meant that it didn't matter how many dialects we did the leaflets in, they weren't accessible to the people that they're being created for. So a lot more use of video was being used, a lot more use of pictures in schools, so you can get that more standardised approach to basic functions around just getting from the classroom to the dining room, for example, but also budgeting children up more effectively, so children arrive with a protective network. So having those things in place for children and young people as they arrive, but videos around health services presented in their native tongue, I think is absolutely crucial, and that needs to be on arrival, not 6 weeks later, that availability of information. And I think we've learned a lot from the way we handled the Afghanistan arrivals, that we can actually apply that learning to the Ukraine situation now.
Mm. Could I add on that issue, because I'm just talking about current cases that I know about young people that are going. The science in schools is well to do, but it is about the mental health of the specificity of these young people, which probably their parents have, but they'll rather have their children be looked into that into those issues to understand better about what can they do. They're in hotels and they come out and they do understand the science and see all these others. Others are going to language schools and doing other things within. But the understanding of mental health, the depression that the young children are going through is one of the things, because after school they go back to their hotels and they don't understand that, and they are saying he's not eating, he's not doing anything, comes home, he's sleeping. But when I look at it myself, I will see that it's mental health, but for them, they are not seeing that things are happening that way. And I was just trying to figure out what's there in place, because there's going to be now the Ukrainians. There's already others that are there that have been put during the time of COVID from different countries, not only Afghanistan, but they are from different parts of the world around Reading. But one of the major issues is mental health.
Yeah. And I think the conversations that I had right at the beginning of this meeting highlighted the challenges of adolescent mental health and access to services. So it's something we're acutely aware of. But I think for particular groups where the specific issues and the difficulty of accessing to services, I think the first conversation should be with the school and see what support can be happening with there alongside their education. And then the school are really well placed to do an assessment of that young person. If like you say, the parents aren't necessarily picking up on it, schools will be, and they will make referrals where they feel it's appropriate to do so. So no child should fall behind, really.
It's a good point, Alice. We need to make sure you're, well briefed and involved in what we do to support schools, and the support is in schools for kids in this situation.
Absolutely.
Thank you. Thanks for raising that. And then Katie.
Yeah, I was just wondering, Alice, do you know of, and I know Councillor Hoskins, you actually raised here that there is already a strong Ukrainian community, but actually is already a community group or organisation that actually we could work alongside in order to start at the very outset with understanding the individual communities' approaches that we know that are going to help them, rather than being, as Tracy's talked about, sometimes that what we tend to do is actually create something which we wouldn't have done beforehand, but there may be some other people might have created it, but actually we know that actually not going to work. We want to get it right first time, really. Are you aware of yeah.
Oh, sorry.
Yeah, I think what is important is to look at what the voluntary sector, because what is to understand is that refugees, because they've been let down by systems themselves, institutions, they would not approach these kind of school things or any organization in that sense. They'll rather approach a voluntary sector where they know people there are working within their own way, but not within the systems itself. So there are a lot of voluntary sectors that are doing around Reading those work, but also they find it difficult in the sense of some the people that are coming there and they're talking about things that are happening at schools, and then how do they relate that information to people, because most of the refugees go to these small voluntary sectors and they are learning English there. They are being helped with their papers. They're being helped about schoolwork and all that. This is micromanaged by these amazing voluntary sectors, but they don't have the mainstream things that they need, especially about these things about health and mental health, where somebody can easily say, there we are there, this is what you're supposed to do with the children. And it has to fit into the voluntary sector more than the bigger institutes, because there are people who have come from same places of big institutes that have let them down. And when they come here, they're always thinking, am I going to the Home Office? Are they going to deport me? But with the voluntary sector are the people that work with them from the bottom, and they assure them and they give them confidence. And this is the place where everything should start.
Okay.
Yeah. So on that note, I mean, I know Jason Brock's been doing this, and the mayor working with the Reading Ukrainian Community Centre, and the group is very, very strong, and that, so that's already starting, and I think ourselves and Wokingham, because they are very strong commitments to make sure that we welcome people in those ways. But yeah, that's you've got those advantages and those strengths. I think it's important.
Thank you.
Thank you.
Everyone for all of that. Right. Okay. Have a great weekend. I think the weather forecast looks good. So.